Live just a moment. You are live now, ma'am.
Very good evening to one and all of you for yet again a very interesting ARC webinar on managing post-op dissatisfaction in cataract surgery. I think it's something like we say cataract surgery is like a breadwinner for an ophthalmologist. I think also being cognizant of how to deal with post-op patient dissatisfaction in cataract surgery is of paramount importance. And today we are truly lucky to have a great set of expert panel and wonderful speakers. And I'm sure you would be glued on to this webinar from 6 to 8:30. So we have on our expert panel, Dr. Jeevan Tityal, who needs absolutely no introduction, an extremely prolific, versatile surgeon. And we know he heads RP Center of Ophthalmic Sciences, New Delhi. And we are going to see the best moments happening in the country at his place during this tenure. We have with us Dr. Ramurthy, who is going to be joining us very soon, who's the chairman of the Eye Foundation Group of Hospitals, our past president and a teacher amongst teachers, to add to some teaching pearls in this meeting. We have with us joining soon Dr. Chi Sufek, who's again a very versatile, amazing surgeon. I wouldn't know how to describe her surgical gymnastics. And she is an assistant professor and from Singapore National Eye Center, senior consultant in cataract, refractive surgery, and also immunology. We have with us joining soon Dr. Ravi Prasad Chella, who's the chairman and managing director of Challa Eye Center, Banjara Hills, Hyderabad. Again, another very versatile surgeon. We have with us on the expert panel, Dr. Rajiv Chaudhary, who's the director of Rajas Eye and Retina Research Center, Indore, and a very innovative, amazing surgeon, which would, and as his quiet personality would never let you know the magic which he has in his hands unless you get to see his surgeries. We have with us again another very dear friend and again an amazing surgeon, Dr. Sandeep Navnekar, a very prolific surgeon who's having a very premium quality practice at Mumbai, and he is going to add to the pearls how to deal with post-op patient dissatisfaction. I'm sure he'll come up with wonderful pearls, believing that the premium practice includes some of these film stars. So we could imagine the kind of patients and tips and tricks he would have up his sleeve. Co-moderating with me is Dr. Satyajit Sinha, who's the chairman and the managing director of AB Eye Hospital, Patna, member ARC East for the second term. Again, an individual who charms entire nation, and I'm sure he is going to see many more posts in his tenure as an AIOS ophthalmologist. And without ado, I shall go on to my talk. Shall I share my screen? Is my screen visible?
Yes, yes, you can see.
Yes, ma'am. Yes.
Yeah. So very good evening to one and all of you. I thought I'd go on as the first batsman in this wonderful series of talk. And my due is to deal on the pearls to hit target emmetropia. I suppose it goes without saying that success is how well you hit the target. In other words, what it actually tries to tell us is how happy your patient is with the distant vision, the intermediate vision, or the near vision, or a combination of both which you promised, and how well he looks at you as a success. And believe me, hitting the target in all of these patients will definitely take you leaps and bounds in your practice. So the next question which comes is, how well are we performing? Just 1 minute. Not able to, excuse me, not able to go to my,
If you click on the slide, it will move.
Click on the slide.
Yeah, I know. It's not going. I think I'm very sorry. I think I'll stop sharing and share again. Oh God, what happened? Can you see my screen?
Yes, ma'am.
Yes, ma'am.
Okay. So then, how well we are performing is the next issue which we need to address. Until some time back, when we were with the third generation formulae, 75% of our patients are well within plus minus 0.5 diopters, and we thought it was acceptable. And these were actually getting worse for unusual eyes or complex eyes. But today, with the fourth generation formula, the fifth and more, we have 90% of our patients who are able to achieve within plus minus 0.5 diopter of target emmetropia, and that seems to do well even in these unusual eyes. When we talk of biometry, it apparently looks to be a simple arithmetic, but then we need to understand that there are a lot of measurements and assumptions which happen here. That when we talk of an IOL power calculation, the values which need to be incorporated is the axial length, the keratometry, and the effective lens position. Of course, the post-op refraction. But the one place where we are near perfect is the axial length measurement. But we are sort of flummoxed with the assumptions which are made with the effective lens position and the K value. So then, how did we go about it? Like if this was a particular case where the patient had perfect 6, and 6, it was perfect measurements and a perfect formula. Is it that there were two errors in this particular formula which canceled out each other? Then you thought you have an answer here, but then you suddenly land up with this kind of a residual refractive error. And with all the promises you've made, you need to have your right answers. So what happened way back in 2008, they found that the effective lens position was a causative factor in 35% of the cases for residual refractive error, the axial length in 27%, the refraction in 17% and more. And then now that we know that we are bang on accurate in majority of our situations with the axial length, with the kind of biometric measurements which we have, and also the fact that we are right with the incisions and our CCC, and the fact that we are nearly able to identify the position of the lens in the capsular bag, we are pretty bang on in our getting to that emmetropic target outcome. But then again, the challenges which continue to remain are the K value and the effective lens position. So does it mean that one formula fits all? Maybe, yes, we could try with multiple formulas for different scenarios, but today, with the fifth generation formulas, the Barretts, we do understand that we are able to address this in majority of our situations, if not all. We have evolved through the regression formula, the Virgin's formula, which was defined with the Gaussian optics, with the different variables which they used to address the effective lens position, and the artificial intelligence and the statistical model, which essentially incorporated a whole lot of post-refractive results to get that kind of effective emmetropic outcome. And the ray tracing formulas were definitely a way forward. But what actually still challenged us, that if the lens sat a little anteriorly in its position, you need to implant a lower IOL part than required. And if it sits a little posteriorly, you need to implant a higher IOL part. And those were the very minuscule challenges which challenge us. However, in normal eyes and normal corneas, we are able to get away with the average regular formulas and are not feeling challenged. But the challenge comes when we are in a situation like a long eye. However, in a long eye, by the very fact the IOL parts being of lower part, the impact on the effective lens position and the refractive outcome is not significant. The only problem is, in majority of the formulas, we tend to overestimate the axial length or the length of the eyeball. However, the challenge becomes entirely different in a short eye because of the high part IOLs which are used, and even a minuscule shift in the IOL part could end up with a very big refractive change. In fact, We are not sure whether it's a normal axial length, a normal anterior chamber, a smaller anterior chamber. We are not sure whether it's increased length thickness, which makes it appear as if it is a smaller anterior chamber depth. Again, if you look at the dimension matrix of the human eye, what you realize that in 73.4% of the eyes, the anterior chamber depth and the axial length are normal, whereas the axial length is short in 6.9% of the eyes. And there are 1.8% of the eyes where both the anterior chamber depth and the axial length are small. There are eyes which have a normal anterior chamber depth, but have a long eye in 13.5% of the cases. And in 1.5% of the cases, both the anterior chamber depth and the axial length are long. So what we realize is there's a whole range of combinations which can present. And towards this, the average formulas work well in most of these normal eyes, but it is these newer formulas which seem to perform well in these extremes of axial length. The other thing which we need to look at is the toricity ratio. Like an average toricity ratio, 1.45 seems to do well for most of the toric IOL implants. But if it is an eye which has a short anterior chamber depth or a larger anterior chamber depth, the effective lens position assumptions are definitely challenged. Like you can see here, for a normal eye, you need a T5. For a small eye, you need T4, and for a large eye, you need a T6 toric IOL. Now, that is where the kind of accuracy is challenged. When you look at the Barrett universal formula, you realize they come up with 5 variables to predict the effective lens position of the eye. We need to know that these are based on thick lens formulae. And what it does is, it is able to tell you exactly what is the position of the IOL in the bag, that is where the lens factor, it tells you about the different changes in the lens, effective lens position based on the different principal planes of the IOL. It tells you whether you need to place a with the rule IOL astigmatism or you're dealing with against the rule astigmatism. It tells you whether you're going to use a Barrett 3K formula, and it uses double K solutions. In other words, the Barrett suit seems to give you a convincing answer for a routine situation for a toric IOL implant and a post-refractive surgery eye. Now, the challenge is, it also tells us that with the changing geometry of the lens, you could be normally using a biconvex lens, but as the powers change, you may go on to a plano-convex or a meniscus lens, and it tells you how the effective lens position or where the IOL sits in the capsular bag, that is the distance from the anterior corneal surface to the optical center of the IOL, where it is exactly placed, could also be defined with the help of this formula. So essentially, you need to have key strategies for better measurements. And the Pearl 2 tells us that we have a range of optical biometers, but we still are doing well with the immersion biometer. The only advantage these optical biometers give is the high frequency of the laser beam, which brings in a great accuracy in our measurement techniques. And the average difference between an ultrasound and an optical is as much as 200 microns. If you're using an immersion biometer, you should concentrate that all the spikes are of equal amplitude, that you're not pressing too much on the cornea, that the standard deviation is within 0.6 diopters. If it is a cornea, we need to see whether it's just a normal cornea, whether you're accurate in your measurements, even if it is an abnormal cornea or the cornea which has been modified surgically. And we have a conglomerate of technologies, like some measuring a 3.2 ring, some like an IOL master having 3 rings to measure the K value, or a lens star which has 2 rings to measure. So further on, we have today the IOL master 700, which takes in information from the anterior corneal surface and the posterior corneal surface and gives us the total arithmetic value, which, if incorporated into the Barrett formulas, gives us the Barrett's toric TK, the Barrett's TK treatment, and gives us all the ranges of formulas. But if again, you're using this total keratometry into those other formulas which have already devised a mathematical model of arriving at the posterior corneal astigmatic measure, we need to be cautious, because you would end up doing an overcorrection. When you're looking at the IOL Master 700, there are, besides a swept sort OCT, it has a B-scan biometry, wherein with the help of both, it measures the corneal thickness, the lens thickness, the fixation check. And what is most important is always measure both eyes in every patient. because herein you find there's a difference in the axial length, and you realize that the toric IOL part calculation values are different in different formulae. Then you immediately like to look at the immersion biometer. You try to remove all the outliers and see whether you are using the average formulas and average values. You see whether the standard deviation is well within normal limits. And then if you try, supposing going back on the day of surgery and repeat an IOL master 700, you realize that that error, which was earlier on because of the dense PSC with the other optical biometer, has been nullified, and you get similar values in all the different formulas which are using. It is also important to remember that an axial length difference of more than 0.3, a K value of more than 1 diopter, or an IOL power of more than 1 diopter, please beware that that could be an error. So you need to evaluate the quality of your raw data. Like in this particular case, there was a difference of 2 diopter of astigmatism between the two eyes. And when you examine the eye carefully on the slit lamp, you realize that this was a severe dry eye status. And then when you treated the dry eye and then go back and do your measurements, you realize that astigmatism is similar magnitude in both eyes. And if this was not factored in, your IOL power calculations could have been wrong. In fact, 60% of our routine cataract patients who look asymptomatic have a tear breakup time of less than 5 seconds, and 50% of them have central corneal staining. So what you realize that the impact on the dry eye disease can give refractive surprises because of the tear or hyperosmolarity changes can bring on an IOL power difference of even more than 0.5 diopters. So you need to explain to your patient beforehand that he has a dry eye disease. You need to treat it rather than being challenged with a symptomatic patient post-cataract surgery. You need to teach your technicians to look at all the LED points, whether it has a fishtail appearance, whether it's in the red or yellow or green, whether the standard deviation was less than 0.2, whether the signal to noise ratio was more than 2. Like these are small issues which become big issues when you're looking at exactitude in emmetropic outcome. So you need to validate your measurements. Like this particular patient had a K value which were different between two eyes. And only then when you dig into your patient's history that he tells you that he had a LASIK surgery done 30 years back. And if he had not factored it and changed your IOL formulas, your IOL power calculation would have been challenged. There are different validation guidelines which come on you in your when your errors, when there's a astigmatic change, when the AC depth is different, when the axial length is different, and all of these have to be looked in carefully. When you're treating astigmatism, it tells you whether it's a with the rule astigmatism, whether it's non-toric IOL, whether it's against the rule astigmatism, and that you need to implant a toric IOL. And this was a particular case wherein the astigmatism was not significant. This was a particular case which tells us that it makes sense to actually do a keratometry before you start counseling your patient, because if he has a toricity, you could actually straight away go on to correcting the toric IOL and take your counseling in that direction. Pearl 7 tells us that when you're doing a multifocal IOL, the threshold for astigmatism is so low. So even if it is a low diopter, and if you're on a femtocataract platform, it makes sense to use those arcuate keratotomies. Now, this was a particular patient who was being planned for a toric IOL. He did have a 0.8 diopter of astigmatism, which was overlooked, and a PanOptix was implanted. And this patient had a small amount of astigmatism, was not happy, convinced him that we would do a laser touch-up after a period of time, and went ahead and did a PanOptix toric and the other eye, looked into all the factors, implanted the right series of toric IOL, and found that this patient, with the laser vision touch-up in the other eye and the other second eye with the PanOptix torics, did well. The Pearl 8 tells us that you need to understand what is it your toric IOL calculator does. Does it measure the posterior corneal astigmatism? Does it look into the toricity ratio specific to different axial length? Does it look into the centroid values? Because if you only looked at the magnitude of the astigmatism, it would tell you that there is this SIA is different. But if you look at the axis, you will find that the axis actually cancels out each other. And overall, what we understand that for any incision 2.8 less than 2.8, the centroid value, 2.4, the centroid value was only 0.1, and that is all needs to be factored. If you have an immersion biometer, you could still feed in all the data from the immersion onto the toric online formulae, But only thing you need to be specific is you add acoustic factor of the IOL constant, and it would tell you what is the axis of placement, what is going to be your residual astigmatism, and how close to target emmetropia you should have. There are certain unusual measurements in unusual eyes, like 70% of the eyes, you're fine with your average formulas. But sometimes you would see you have a dry eye status which needs to be addressed. Some of these patients, you need to do a tomography, need to understand the posterior corneal astigmatism, need to understand whether there's an irregular astigmatism, whether you need to use specific formulae. You would find that in a post-LASIK eye, you need to look at the higher order abrasions which are induced in these eyes. Would these patients do well? Is the angle alpha within normal limits? Whether this patient would do well with a premium IOL, whether the astigmatism is orthogonal in these eyes, whether the symmetry of the topography is normal. You have looked into range of values, but then you need to understand that yes, the optical biometer seems to be doing the best, but you need to verify the raw data at all times. You need to validate your measurements. You cannot remove yourself from the process of IOL power calculation, even if your optometrist is doing extremely well. You need to ensure that you're using the right choice of formulae. You need to treat the astigmatism. And believe me, if you have the right IOL and you have combined it with perfect surgery, you are bang on. But yet there's one small sorry tale, that effective lens position is seen to shift post-operatively too. And this was a study which tells us that the anterior chamber depth can shift for by more than 1 millimeter from 1 hour to 2 months. So in other words, you think you have nailed the ELP, which is the challenge for target emmetropic outcome. And this could actually change as the patient heals. And this is where you're stuck. This is where you're waiting for a breakthrough technology, which gives us that final answer which we need in our post-op IOL power adjustment tool, so that we are just where you need to have a target emmetropic outcome in every single case of ours. Thank you. Now.
Thank you, ma'am. That was a very, very nice presentation, ma'am. I have one question. A lot of us have IOL Master 500 and that doesn't give you the posterior curvature measurements. How important is posterior curvature measurements? Would upgrading to IOL Master 700 give a better patient satisfaction? What are your thoughts on this?
Definitely incorporating the posterior corneal astigmatism, either by directly measuring with the IOL Master 700 or going in using a Barrett formulae, which has its own mathematical model for calculating the posterior corneal astigmatism. It is at what level? I mean, you need to understand, you could even use an immersion and use all its values and feed in online onto the Barrett's formulae. With the acoustic IOL constant, you could still do pretty well if your surgical steps are doing very well. If you have access to the IOL Master 700, yes, it definitely brings in that amount of precision in your end outcomes. I was just wondering whether our second speaker was to be, I was wondering whether Dr. Ramurthy, would it be okay for you to become our second speaker? Because yeah, sorry.
Can I have a question, Chitra?
Yeah, I was wondering whether you could take all these questions after his talk, because I just realized that he's also going to be talking on residual refractive error.
Okay.
Let us hear our talk and then take all the question and answer for this session. I'm sorry, Ramurthy, I'm making a change in this last minute. If your screen is open. So Dr. Ramurthy is going to be talking on bioptics, when and how. And I'm sure he would be telling us, I have told you how to address target emmetropia. And he is going to tell us, okay, you are stuck with a residual refractive error after cataract surgery. How best are you going to deal with this?
You can see my slides?
Yes.
Okay, thank you. I think that was a fairly extensive talk on how to arrive at target emmetropia. And as Chitra mentioned, if in case you are left with a residual refractive error, how exactly can you deal with it? Whenever you are prescribing spectacles subsequent to cataract surgery, there is a certain amount of unhappiness that's associated with it. Not only that, whenever there is significant refractive error that's left over, it can also translate into malpractice risk for the practicing ophthalmologist. And this is something well established with several studies. So exactly, it is not only important to have access to all the formulae, the technology that Chitra talked about, but also have the ability to deal with them in case you are faced with a unequivocal situation. So obviously, when you have a residual refractive error, the best way is to prevent it. And sometimes the patients are also willing to go ahead with purchase a pair of glasses for specific purposes, just because you have never offered them or promised them absolute freedom from glasses. Laser vision correction, piggyback intraocular lenses, IOL exchange, IOL repositioning are factors that I will be covering. And interestingly for me, the fellow eye surgery is also a very important method of dealing with patients who have had some residual error in the first time. Transepithelial PRK is what we favor most often when there is a residual error. And often these patients are promised even before the primary surgery, when they're going for a toric or a multifocal intraocular lens, that there might be a need for a touch-up procedure, which will be offered free of cost at around 3 months. And often it's not just the need for glasses that goes away, but even if they have some problems with dysphotopsia, it significantly comes down. Invariably, it's small errors of refractive error that needs to be dealt with. And that's a mitomycin C, which is placed upon the corneal surface for a period of 30 seconds, irrespective of the amount of refractive error that we deal with. Some of these patients who have epithelial issues because of their age, as well as those who are averse to the irritation that it causes, because we are doing it free of cost, we most often end up using a microkeratome till I believe 25 years from the time I started refractive surgery. That's a very useful tool. And you can see the intraocular lens shining through. And very often when you address the small amounts of refractive error that these patients have, the ability to deal with it often translates to a very successful outcome in these patients. When there is a significant amount of refractive error that's left over, especially in the hyperopic error, for example, this patient was post-refractive surgery, surgery done quite some time back, had an error of +4 diopters, and it's a week later that we are actually explanting this intraocular lens. In case you can bring out the haptic like this, then you can create a small cut of the optic to a quarter of the length of the, half the length of the optics. Otherwise, you can go through the side port incision using specific lens holding forceps. And then once you have got hold on this, and you can rotate the lens out of the bag and then implant the intraocular lens of the right power inside the eye. And ideally, it should be done, especially when you are implanting a hydrophobic acrylic lens, within a period of a couple of weeks. And in case you are faced with a significant refractive error, this is one of the best ways of dealing with that, especially in the early periods. The other lens that I often resort to is a sulcus implantation of the intraocular lens, where you can see there is an anterior convexity and a posterior concavity. Because of the posterior concavity, there is a significant length distance between the primary lens and the secondary lens. And I use this whenever I'm faced with a situation where there's a significant residual error. And as you can see, this lens is about 14 millimeters in overall diameter, having a 6.5 millimeter optic diameter. And you can see this capsule is open. Here again, the simple formula is that for every diopter of hyperopia, you have a 1.5 diopters in the sulcoflex lens. And for every diopter of myopia is 1 diopter of myopic error that you correct. Here there was a 6 diopters of refractive error that was left over. And this is a +9 diopter intraocular lens, a sulcoflex lens that's being implanted. And as you can see, the primary lens is in the bag, while this lens goes into the sulcus. Often they are of different material. And you also ensure that the haptics of the two lenses are not exactly in line with each other, but at 90 degrees to each other. This lens, again, this was actually a planned sulcoflex lens. Actually, several formulae were showing extremely different IOL power calculation in this hyperopic eye, non-ophthalmic eye. And essentially what we thought that the patient was needing a +56 diopter intraocular lens. In these patients, you can see a +40 diopter single piece intraocular lens has already been placed in the eye. And subsequently, what we found was that the patient had a +6 diopter residual error. And again, you can see a +9 diopter intraocular lens being implanted in the sulcus. So in this case, actually, the patient was told that it would be a two-stage surgery. Of course, you can get intraocular lenses of high power being manufactured and given to you. And these lenses come with a considerable amount of spherical aberration. And I often find that the intraocular lens power calculation itself is a challenge in these situations. So a two-stage surgery like this is often helpful in dealing with the situation. This is just to show you the OCT picture of the previous surgery that I showed. And you can see the distance of about 510 microns between the primary and the secondary lens. And this is a slit lamp photograph of the patient who has been dealt with. Today, you also have a situation where the patients who are coming in for a multifocal intraocular lens in the second eye, and often I dissuade them from that, but then in case they're insistent, we go ahead and implant the lens. That serves the patients quite well, but sometimes they want something for the initial eye where they had a monofocal lens, and you have the trifocal piggyback intraocular lenses available to you today, and this is what I'm implanting in 2 of my patients. It's not that we actively encourage this, but in case the patients having seen their relative or a friend enjoying the benefits of multifocality wants this, then this I find is a fairly true and tested technology. And I have implanted about 12 of these eyes so far. And I find that the trifocal optics of these lenses, where you can even get a power incorporated or even astigmatism corrected, does act quite well and ends up in satisfactory patients. Here is a situation where you find that there is a toric intraocular lens that has been implanted. The patient has an excellent refractive outcome. It was done in a nearby town by a very good friend of mine and an excellent surgeon. The patient was a lawyer, had an optimal refractive outcome, but was extremely disturbed as far as the dysphotopsia was concerned. Was followed up almost for a period of 6 months, but then because he kept complaining, he was subsequently referred to me. I did not want to disturb the capsule because the toric lens was very well placed and the patient was enjoying a very good refractive outcome. But I went ahead and placed a sulcoflex lens of just 0.5 diopters. I would have preferred a 0 diopter, but that was not available. And the moment I did this, the first post-operative day, because the rounded optics of the sulcoflex lens was overhanging the square edge optics of the primary lens, the dysphotopsia that the patient had to live with and was getting disturbed with for almost a period of 6 months almost vanished. There's just one way of dealing with severe negative dysphotopsia. Of course, doing a YAG laser to the capsule which is overlapping is also a good way. Then, of course, the toric intraocular lens rotation. I have a Varion overlay in this situation, but that's not being seen in the videograph. So you can see there's a significant rotation that has occurred in this. And even for much lesser rotation, I use a Barrett RX formula, which gives you an idea about what exactly is the extent of rotation that this lens has to undergo. And it's just an irrigation cannula that goes in through one side port and using a Sinskey hook. Usually it's at 1 to 2 weeks period. If the patient needs rotation, that I go ahead and do this, and you can see that it does well. It has also been suggested in these situations, you can combine it with the implantation of an endocapsular ring, which might avoid the further rotation of the intraocular lenses. But I personally do not subscribe to my view. And I find that just rotating the lens and evacuating viscoelastic completely, that's the reason I don't use any viscoelastic in this situation, does help in stabilizing the lens, leading on to optimal outcomes. It's also important that you decide what patients actually need treatment. You can see a patient like this, a 6'9", and 6 vision in one eye, 6'6", and 6 in the other eye. Patient came in feeling extremely happy with his condition, but often your optometrist finds out that there's a 0.75 diopter of astigmatism left over. If they go ahead and make the patient realize that the last line is not so clear to them, a happy patient who walked into your clinic turns into an unhappy patient. So I often emphasize to my patients what we are looking, my optometrists, my other doctors, what we are looking at is 6 by happy rather than 6 by 6. So do not create a problem when there is none. If a patient is quite happy with the outcome that you have achieved, don't go looking around for that small 0.5 diopters of astigmatism or cylinder. On the other hand, you're faced with a situation like this, where the patient has 6 by 7.5 vision recorded by one of my junior optometrists, but the patient came in with a complaint of blurred vision in the right eye, having him got a toric multifocal intraocular lens implanted. So I asked one of my senior optometrists to repeat the refraction, and this is what he ended up with. A 612 uncorrected visual acuity and just a 0.5 minus 0.25 with a minus 0.5 diopter of cylinder. But since the patient was not happy with the visual outcome, we went ahead and performed a laser vision correction. This was a toric multifocal that was implanted, but when it's a myopic astigmatism and both the myopia and the cylinder are minus, rotating this lens is not going to help. So essentially what we did was to go ahead and do a laser vision correction. And another important factor that I find is that fellow eye surgery often takes care of the problems that you created with the first eye surgery. You can see fairly straightforward intraocular lens power calculation. Patient received a Symphony intraocular lens. That was, I think, sometime in 2019. As we all know, the patient had a significant presbyopic correction, had an excellent visual outcome as far as distant vision is concerned. So what I did was to do a bit of a micro monovision in the second eye, where instead of 22.5, I went ahead and implanted a 23 diopter lens. So bilaterally implanted, what we found was that the patient achieved an excellent near vision. He was aware of the fact that there was his near vision was not so great in the other eye, but bilaterally implanted, the patient was quite happy. So essentially, I find that fixing refractive surprises in cataract surgery is essential, and it's possible, and is an integral part of refractive cataract surgery. And that's something that we need to do in our day-to-day practice today. Thank you so much for your kind attention.
That was a wonderful talk, and I think it practically answers most of the questions which all of us have. But again, for the questions for the experts on the panel, how long do you think we would wait before we go ahead and do a bioptics or a touch-up procedure? Dr. Sandeep?
Well, Chitra, it depends on the magnitude of the refractive error. It's like if the refractive error is small, and if the patient has got the other eye to be performed as well, I would first go ahead and, as Ram said, get the cataract surgery done for the other eye. And if the patient is okay with that, maybe I would tie it on for some time. But if it comes to a refractive error correction at the end, and if I have to do a laser vision correction, I would do for these small cases, I would wait for up to 3 months and then do it. However, if there is a large refractive error that has come in, then maybe we need to go in a little more urgently. It might even involve exchange of the IOL, or I could do a laser vision correction, but I would do it sooner than 3 months.
Dr. Rajiv, you had a question?
Yes, I just wanted to ask you, you were mentioning about the effective lens position.
Yeah.
Especially in the myopic eyes, when there is a lens power is minimum, so there is a change in effective lens power. It doesn't alter much the intraocular lens power calculation. Yes. But when the LASIK operated, so that your lens power is higher, and many times we feel that myopic eyes, that once to your irrigation aspiration, that effective lens position is ALP is not exactly where we think. So does it make a difference? And can we assess it prior to in a LASIK operated myopic patient? Because
in a LASIK operated myopic patient, the regular formula is not going to be there. We are going to use a Parrot RX formula.
Yeah.
2K formula. So when you're using that, it factors in all those aspects which are there. It is not just the alteration on the cornea. The relationship of the anterior and the posterior cornea is altered. That is factored in, and the axial length and the depth of the anterior chamber depth, everything gets factored in. So it uses a double K solution. So it is different for the regular universal formula and becomes different.
That's okay, but then it is very case to case. Many times we feel that chamber is so deep, and many times that chamber is not so deep. Yes. So it might be going to affect the effective lens position, because sometimes the journals are weak. That might be creating that position slightly backward, and if journals are not weak, it will be slightly forward.
Yes, true. Yes, true. those zonular weakness is an entirely different ballgame. That is going to bring in a lot of its refractive surprises. So then we are looking at the stability of the capsular bag, and when there is a doubt on that, then you would have to put a CTR. But the fluctuation of anterior chamber depth during the surgery is not going to affect the post-op outcome, because once the eye becomes stable and it's in the IOL is seated well in the capsular bag with the nice overlap, I think that would be the post-op situation which is factored in these formulas. I'm sure I want the other expert panels to give their thoughts to what he's trying to ask. Dr. Ramurthy?
No, I think what Dr. Rajiv is trying to ask is that, in a highly myopic patient, you have a large eye, you have a large capsular bag. But because he has the patient has undergone a prior refractive surgery, the IOL power that you might implanting might be a little different. And what exactly would be the impact of the position of the lens in that large capsular bag? Am I right, Rajiv?
Yes.
That fluctuation, because effective
Yes.
lens position in the larger power, it will be affect much the postoperative refractive outcome instead of
if I might, even Satyajit had asked this question, I think one of the advantages of, for example, when you are mathematically assuming the posterior corneal curvature and actually measuring, as in the TK formula, when in the universal 2 formula, etc., it doesn't really make too much of a difference. But when it comes to a post-classic eye, in which case there's the relationship between the anterior corneal surface and the posterior corneal surface is altered, actual measurement of the posterior cornea does help more significantly than the mathematical assumption in the original Barrett formula. And as far as the profile of the lens itself is concerned, Chitra also mentioned during her talk that these lenses are taking into consideration the shape of the lens, the shape factor, the principle. When you talk about the lens thickness in other formula, it essentially refers to the thickness of the lens that we are taking out. The Barrett formula is one which takes into consideration the lens and the profile of the lens which is being implanted. So whether it's a meniscus lens or a biconvex lens or a plano-concave lens, the principal meridian is going to vary, and that's being factored in. And that's the reason that you do not really have to compensate for the intraocular lens power that you are implanting. Whether it's a +30 lens or whether it's a -4 lens, quite often I find that it's the Barrett works well.
Okay. In a post-classic eye, if the patient has a smaller residual error, would you still like to go and treat on the post-classic cornea, or would you rather place it in the sulcus? Dr. Kamal Kapoor wants to answer that.
Yeah. See, Dr. Chitra, I think, first of all, I'm really sorry for joining late. There was some emergency I got caught in, but I think better late than never. It depends. What is the post-operative time period? Let's say this patient has got a minor error, which is just maybe immediately post-op. So then you know that there's some issue with your machine, the settings or the OT or whatever. Then probably I would not hesitate to lift the flap and probably ablate the cornea rather than open the eye and put in an IOL. But let us say I see this patient after a period of time, let's say 2 years, 3 years. That is the time I would like to watch out before I touch the cornea, because, sometimes these corneas have some creeping issues, hidden issues, which they are probably, manifesting 3, 4, 5 years post down the line. So just probably do their posterior corneal curvatures, do their pentacams, and observe is there something happening there or not. And if I'm not sure, either I would refrain, tell the patient to wear sunglasses, maybe if it's a small little power, or if I need to decide for surgery, and if I'm slight doubt, I would go in for a piggyback lens. That's for my personal opinion.
See, I don't think in an older age group, ectasia is going to be a problem. You should have looked into the ectasia before you go in for a premium IOL implantation anyway. So probably I was just wondering that you would not touch the cornea if the aberrations are more.
Absolutely.
Do you want to add anything to it? You are muted, Dr. Naren.
Thank you, ma'am. So in terms of aberrations, definitely, let's say preoperatively itself, if I'm seeing a lot of abrasions, I would take that first as primary, provided it is safe to do that kind of a treatment in that particular eye. And so that my predictions, once the cornea is much more regular, my K readings are much more reliable. And, and the position, the post-surgery also, patient will be seeing fantastic, even without treating it. If you put a monofocal lens, patients still have a little bit of glare and, some amount of disturbance because of the lot of aberrations in the eye. I would prefer to regularize it first and then plan for the cataract surgery, definitely.
We shall go on to our next speakers. I'm sure there's going to be a lot more information which will come in, and that is going to add light. Samesh, I'm very sorry. I know you were a second, you became the third, but no, you have to stop sharing for a moment. Dr. Srinivas has an emergency to attend to. So he just now requested that he would like to give his talk. So, so our next speaker is going to be Dr. Srinivas Joshi, who's going to change gears. But that is again a very relevant part of dealing with post-op patient dissatisfaction. When we are all talking about cornea and bioptics and a piggyback lens, there is something in the back of the retina, back of the eye, which needs to be looked into. And Srinivas Joshi needs no introduction, an extremely versatile, amazing vitreoretinal surgeon and a member ARC South, and literally a right hand for me in my ARC ventures. And I'm sure he has a great future ahead, and he's going to be talking to us on current concepts in prevention and treatment of CME. On to you, Srinivas.
Thank you, madam. Thank you so much. And as always, you have been very supportive, and all the ARC members, we are very thankful to you. I once again welcome all the expert panel and the speakers for this ARC program. Thank you, Chitra madam, for giving this opportunity. And I request pardon from Samaresh for just skipping by one speaker. Sorry, Samaresh. So I'll be speaking on the current concepts in the prevention and management of CME. So this is the case one, 65-year-old male, complains of diminution of vision in the right eye since 10 days. So he's a diabetic, 5 years on oral hypoglycemics, both eye cataract surgery done 2 months ago. And left eye, if you see 6 vision, and both eye quite pseudophakia. So when we look into the fundus features, it was featureless. It was absolutely, there was no findings. But however, if you see very carefully here, there was a little dull FR as compared to the left eye. When OCT was done, definitely you can see the cyst. In which layer? I will come to it a little later. So this is the another case, 55-year-old male on diabetes since 15 years. After the surgery, the patient complains of blurring of vision. Again, if you see the same eye which was operated. Now, when you see the clinical picture, not much, but definitely when you look into the 78D or 98D, it's very hard to miss the minutest micro aneurysms which are seen in this area. And when we look into the OCT, definitely you can see some cysts and you can see some microaneurysms and the hard exudate. So differentiation between the two, we'll come to it a little later. So what's the etiology for the CME? It can be vascular, it can be a diabetic macular edema, vein occlusion, or hypertensive retinopathy, or it could be a PCME, what we call it as a Irwin gas syndrome, or it could be an inflammatory conditions, retinal dystrophies like golden fiber syndrome, drug-induced, sometimes the glitazones itself, where the patients keep using for the oral hypoglycemia, that itself might cause the macular edema, prostaglandin analogs, and definitely the tractional component is the ERM, VMT, and the FTMH. So most common causes are the diabetic macular edema and the pseudophakic macular edema, what I described as a PCME. So we all know that the DME characteristically accumulates in the outer nuclear layers, that is in the ONL, and the Henle's layer rather than the fluid in the innermost layer. What about it? I'll come to it a little later. So what about the factors associated with increased risk of PCME? It could be various ocular conditions like vascular diseases, diabetes, CNVM, certain drugs, certain retinal dystrophies, retinal detachment, optic nerve head abnormalities, including optic pit, optic nerve coloboma, vitreous surgery, laser. They all might cause increase in the PCME. Surgery, we all know that additional trauma, especially handling of the iris or posterior capsular rupture, vitreous loss, vitreous traction, and high phaco energy, especially and also during the long duration of the surgery, are associated with increased risk for PCME. Now, this is the ETDRS grid, which I have shown here. So basically, if you see the Irving gas and uveitic CME, they both are very similar as on the OCT picture. But if you look into the mechanism, Irving gas is because mainly with the prostaglandins, and uveitic CME, say, I'm not talking about the dense vitritis where it's very obvious and we can definitely diagnose it, but in grade 1 vitritis, when there are trace cells, but patient having an intermediate uveitis, so these are the patients who usually they have a T cell cytokines or the CD4 cell immunomodulation. So when we look into the ETDRS subgrids, say 1 mm, 3 mm circle and 6 mm circle, so this is how ETDRS has described the macular edema in these various common differential diagnoses. So if you look into the CRVO, in almost all the subgrids, subset of these grids usually have the cysts. But whereas the important for us is mainly uveitic CME and Irving gas. Irving gas is mainly to the central subgrid only, whereas uveitic CME might extend to the outer circle. However, BRVO, we know superior temporal, they have a cone shaped either superior. If it's infratemporal, they have cone shaped either the inferior. So now if given this diagram, so how we can say that what is what? Definitely this one, if you see the top, the first one, you see the cysts are in the outer nuclear layer. And along with that, you see some HRF, what we call hyperreflective foci. So these are basically seen most commonly in the diabetic macular edema. That is, it might have an adjuvant hard exudates as well. Now, the next important for me is to see from C to E, because which is pretty much similar. But for me, the FE looks similar because it is symmetrically, if you see, it's a symmetrical type of macular edema on both the sides. It's a center involving. The cysts are mainly in the INL layer. Later on, it might go into the ONL, but definitely there is absence of foci in these areas. And this, if you see, this is a uveitic CME. So it is a slightly broader as compared to the PCME, that is pseudophakic macular edema. So what's the main difference between DME and pseudophakic CME? I think just in the last week, Tithial sir was asking this question. Is the macular edema pattern? The DME has the diffuse or the focal, whereas pseudophakic CME is very much central. And location of the cyst, usually it is ONL and HNL Henle's layer in case of DME, whereas it is mainly INL in case of pseudophakic CME. And most importantly, you should know this presence of this hard exudates or the foci and all those things. Hard exudates usually cast a shadow. That is why we call it as a hard exudates. But whereas this has not casted a shadow, which is a precursor of the hard exudates, which we described as a hyperreflective foci. And however, the hyperreflectivity lines of the outer retina is usually disrupted in DME, but they are usually preserved in case of CME. So this is again another picture. If you can see here, you can see this hard exudates casting a shadow here. These are the multiple hyperreflective foci or the dots which are not casting. The cystoid spaces are mainly in the ONL. But here, if you see, in case of CME here, you can see definitely there is a subfoveal fluid and the fluid mainly in the INL, but in turn, they might go into the ONL as well. So what are the treatment, what we have? We have NSAIDs, we have corticosteroids, anti-VEGF, carbonic anhydrase inhibitors, and definitely pharmacovitriolisis. So role of ocular steroids, we all know very well, stabilize the blood retinal barrier, downregulate the VEGF, and inhibit the production of prostaglandins and the pro-inflammatory cytokines. So this is very important, we need to know. We all know that corticosteroid basically inhibits the phospholipase A2, which goes in, gives up the arachidonic acid. This goes into the leukotriene cycle. This goes into the cyclooxygenase cycle. So what is most important for us is the COX-2, which are abundantly found in the RP. So we need to inhibit mainly the COX-2 inhibitors, which are mainly because of the NSAIDs. So currently there are different types of corticosteroid, but in India, most commonly used is the dexamethasone implant, and fluocinolone has not been available yet. But however, intravitreal triamcinolone can also be used as an intravitreal steroid injection. NSAIDs, we all, as I said earlier, it inhibits the cyclooxygenase enzyme that decrease the production of prostaglandin. There are different plethora of NSAIDs available in the market. But let's look into this paper by AAO, which says that we found high quality evidence that topical NSAIDs are more effective than topical steroids in preventing PCME. This is by AIO in 2014. Now let's look into this meta-analysis published in 2021. So the PubMed database for randomized controlled trials, since 2000, they have seen into various clinical trials, and they found out that clinical practice and theoretical background support topical non-steroidal anti-inflammatory drugs as the first-line therapy. Invasive procedures such as periocular steroids, intravitreal corticosteroids, and anti-VEGF are usually in the prolonged or the refractive cases of PCME. This is another study, comparison of efficacy of Dex, Nepafinac, and Bromfenac, and it has shown that not one drug alone, but combination of steroid with either Nepafinac or Bromfenac has shown to have a favorable outcomes. This is another study, comparison subtenon triamcinolone acetonide, which is my favorite, with the topical Nepafinac for the treatment. However, this study has shown that topical Nepafinac is more efficacious than subtenon in terms of visual gain and its correlation with reduction in central retinal thickness. So these are few of the pictures when they come to the retina clinic, and when the intersegment surgeons refer, it could be a PCME. These are the pictures, very typical what we see of PCME. One shot of PST, you can see within just 1 week or 2 weeks, the patient will be fine. This is another picture who has SFF, who have cystoid spaces, multiple cystoid spaces. Again, one shot of PST, it's gone. This is another picture, just showing you a few of the examples with efficacy of the posterior subtenons injections as well. So last slide, topical Bromfenac reduces the multiple inflammatory cytokines as published in this, again, 2021, which they say that in the aqueous sample taken, they have shown that the platelet-derived growth factor, and when we compared it to the fluorometholone, they found out that Bromfenac significantly decreases the VEGF factor as well as the monocyte chemoattractant protein, which was elevated for a long period after phacoemulsification. So these are few of the drugs, again, which has a little bit of controversy, which says that since it's a non-FDA approved drugs, do we have to use it? But last, I would like to say of this study, which is done in 2015, which says that although dosing of NSAIDs before surgery may accelerate visual recovery within the first several weeks after cataract surgery, but there is no level 1 evidence to support the long-term use of NSAIDs in preventing vision loss secondary to PCME after cataract surgery. So vitriolytic agents, and if there is a traction like this, if there is a VMT, vitreomacular traction, then definitely you can use either a pharmacolytic, or it's better to use a surgical option to remove the traction. Thank you very much for the patient listening. I would like to acknowledge Department of Vitreoretina and my fellow for picking up the cases for me, Dr. Rohan Dedia.
Wonderful talk, Srinivas. That was so enlightening and informative to all of us. I think first I would also like to welcome Dr. Sue Fekchi and Dr. Beva Savda. Though they joined late, I'm sure they're going to add to the discussion. I just have very basic questions. I would want more interesting questions with the expert panel. Srinivas, like supposing the first eye has had a CME, does it make sense in using a prophylactic pre-op NSAID earlier on in the other eye?
Yeah, it makes sense, madam. And most of the surgeons, we definitely use that. But when we look into any of these clinical evidences, there has not been any paper which says that, yes, using this preoperatively, it has a long-term effect, or not using this preoperatively has a long-term effect. But definitely when you look into the clinical evidence, the clinical acumen, and what response the patients are showing, many of the surgeons have given up, and they have said it in most of their case reports also, that they do use preoperatively and postoperatively at least for 1 month or 1.5 months.
More anecdotally, although all of us do start steroids and NSAIDs together, does it make sense that you use NSAIDs later, start off with the topical steroids? Theoretical discussion, would you want to add the NSAIDs later, or you feel both should start at the same time?
Madam, if you ask me, most of the papers have shown that it should be both complementing with each other. That is what many of the papers have shown. There's no. I tried to look into it, did a PubMed searching, but I couldn't find that definitely we need to start with steroid first and later on, because last slide which I showed has definitely shown that the NSAIDs has no long-term effect if you use it after 3 months. So basically it is because most of the time we have this between 4 weeks to 3 months. The CME usually happens between 4 weeks. It's peaking at the 6th week. So it makes sense to use this around that time, that is around from 1 month to 6 weeks, so that you don't have that peak of PCME.
A diabetic CME in one eye. For the other eye, would you think of changing the steroid drops, or what would be the topical steroid drop would you prefer, or there is no need to be specific on that?
Diabetic pathology, it's very much different, madam. If they have a DME, which I showed it in the OCT pictures, like if they have this hyperreflective foci, or some authors have even called it as a microfoci, if they have any hard exudates, if they have any microaneurysms, it very much indicates that it is a case of DME. And DME with topical will never go. It has to be treated intravitreally. And again, there are a lot of OCT biomarkers where we need to see which one fares better for steroids and which one fares better for anti-VEGF. Although the first line of treatment, when you know that it looks more like a DME, because you see a small microaneurysm in the OCT, and beside that you see a small cyst basically in the outer nuclear layer. It gives you more confidence that it looks more like a DME. So that is when we switch to anti-VEGF. But if there are too many hyperreflective foci and very tall, large cystoid spaces, and in those cases, I think it's better to switch to intravitreal steroids.
Yes, Dr. Basavda, yes.
Yeah, I think the point you raised of the second eye is very important. And I want to caution operating the second eye too early. You can operate in a normal situation of 1 week, 2 weeks, or whatever, but the eyes which you are suspecting CME postoperatively, all the high risk factors, please wait for 3 to 4 weeks before you operate second eye. I had a very bad experience of doing on the second week of the second eye, and both the eyes developed on the third week of each post-operative cystoid macular edema. It was very embarrassing, and it took time, but I think if you're suspecting that this is a likely candidate, do all what you say, but do not operate the second eye until that 3 or 4 weeks time that Dr. Joshi mentioned is negotiated well. Thank you.
Yes. Any other thoughts before Srinivas moves out? Any other relevant question we want to ask about the CME and post-op patient satisfaction?
There could be instances where the CME and CSME could be coexistent. The patient already has a CSME, you have controlled it with your intravitreal steroids, then subsequently the patient comes in for a cataract surgery, and there is a flare-up post-cataract surgery. How will you manage these situations?
Very good question, sir. Actually,
what is CSME, DR? CSME? What is that?
That's a clinically significant macular edema. That's the ETDRS classification of
diabetic. Okay.
Okay, diabetic macular edema. It's a very good question, Ramurthy sir. In fact, the confusion happens when the patient is already a diabetic and he has a DME, and then we do a phacosurgery, then he has a CME, though the confounding factors present is between the PCME and the DME. So the first important point here is usually when there is a CSME, it's always better to first control the CSME, do an OCT. If it's a center involving, give the intravitreal anti-VEGF injections, and then you can go ahead with the phacosurgery. I have seen in certain instances where some authors, some surgeons prefer doing phaco as well as anti-VEGF in the same shot. Or if the OCT biomarkers show that it's a kind of chronic DME, then phaco foldable along with the intravitreal steroid, that is a DEX implant. So these are the things which can be done on the day, or it's always better to first try to treat the DME and then go in for the phacosurgery.
Yes. I think that's a very important, a lot of important messages came through, like OCT is a huge role play in our diagnosis and management. And thanks a lot, Srinivas. I hope you're able to combine and come back.
Sure, I'll come back. Yeah, thank you. Thank you.
So we go on to a much awaited speaker, Dr. Samresh Srivastav, who's a Senior Consultant or Managing Director of Raghudeep Eye Hospital, Ahmedabad, cataract and refractive surgeon. And he's going to talk on a very interesting topic, dysphotopsia management. It is not too common a problem, but it can be a very bothersome patient if you do not know how to handle the situation. On to you, Samresh. Are you unmuted?
Yeah, am I audible now?
Yeah.
Sorry about this. So I'm going to be discussing about dysphotopsia. And dysphotopsia is not an exclusive diagnosis, but it includes probably all the bad visual phenomenon that patients have when they come to us post-operatively. Despite doing whatever surgery we do and despite using the best of equipment and the best of IOLs, it's not uncommon to see dissatisfied patients. It's not like you see them every day, but when they are there, it's a 6x6 patient which is unhappy, which is exactly what Dr. Ramamurthy sir was saying. You have to figure out what's causing the bother. Dysphotopsia has been defined as an optical phenomenon that happens in patients who have undergone cataract surgery with an IOL, and it reduces the quality of vision. It's been grossly classified as positive, which means photic phenomenon like flashes and glare and halos, and negative dysphotopsia, which essentially means some sort of a shadow, which a lot of patients will complain, a temporal shadow that they see immediately post-operative that lasts them for some time. Positive dysphotopsias are far more common, and I guess we already understand the reasons why it happens. Most of the time, things like halos, starburst, glare, and a combination of either of these can be there in any IOL that is implanted, especially in the first few weeks. Glare is a subjective discomfort that you can, it's probably one of the most common symptoms that is over there. And it generally happens in patients post-cataract surgery who have larger mesopic pupils or scotopic pupils, which again is not very common in our subcontinent because of our pigmented iris. But if it's there, a good idea would be to put them on some sort of medication that brings down their pupil. Something like a brimonidine would normally help in eyes like this. Starburst is again linear lights that are there around the point source. I have no cataract, but I see starburst if I focus on headlights, particularly when I'm driving at a highway. So I'm guessing a lot of these patients will complain of starburst because they're seeing light after a long time, after a long haul of cataract. And because for some reason, patients want to look at the headlights after a cataract surgery, which they would never otherwise look on a routine day-to-day lifestyle, but they tend to try and challenge their lenses. Sometimes starburst can also be due to, starburst like this can also be due to astigmatism, residual astigmatism, as low as half a diopter can sometimes create a starburst-like image in these patients. If the problem is residual astigmatism, even if it's a light diopter, there is no ego in not prescribing them these refraction, and I would go ahead and give them a light correction, particularly in challenging situations like night driving. Flare is another version of positive dysphotopsia where you see a light that is around the object, which is basically could be a combination of a starburst, coma, and a little bit of cylinder can also play a role. For anything like a starburst or a cylinder, you can give a glass with maybe a tint or a night driving glass. Cylinder correction of, like I said, of even lower magnitudes can give a significant benefit to the patient and can help us pinpoint the diagnosis and give them a right solution. Problem is if an IOL is decentered. So if the lens is decentered, what you get on a manifest refraction is a cylinder, but what you get on an aberrometry is a coma. And coma is something that you can never really treat at a spectacle plane. These will be a little more challenging as patients. So if it's a decentered IOL early on, maybe you could do something about the IOL and try to bring it back in place, which I doubt it will, because if it's decentered in the first place, it's going to most likely decenter again. And this can be a little more challenging in terms of positive dysphotopsias. Negative dysphotopsia, the most common form of negative dysphotopsia is sort of a shadow that is seen on the temporal part of the patient's vision, with most surgeries being temporal clear corneal. It could be due to corneal edema in the initial phases, and it tends to resolve over a period of 3 to 6 weeks as the incision seals off. But sometimes it can persist for longer time durations. And that is, it is attributed to many things like an IOL with a high thick lens, larger nasal capsular axis cover, like Dr. Ramamurthy sir brought about a square-edged optic, and larger pupil size amongst all. Again, it has been defined as a temporal darkness, and a lot of these depictions will be available. Patients normally say that they feel that something is there on the side, and a lot of times you would dilate to check patients if the retina is getting detached of all, but it's just classical. Now, with a few patients, one understands that it is temporal dysphotopsia. It tends to go away when you look in the direction of the dysphotopsia, and it tends to get worse when you look in the opposite direction. Again, like we discussed, square edge optics are known to cause more dysphotopsias because of the design of the lens, which we just briefly discussed. And there have been a lot of studies, one published in JCRS some time back, shows that it's the material, the design of the lens, and the asymmetric design that can sometimes cause it. And it also concluded that it's a good idea to have a 360-degree symmetrical overlap over the end of the anterior capsule, which can help in preventing dysphotopsias. And if you do have a dysphotopsia, the myopic therapy may be useful. So with the square edge design, there is a lot of, because it's a sharp edge, square edge is an excellent design, one of the breakthroughs in IOL technology to prevent posterior capsular opacification. But at the same time, you know, there's a trade-off, and it sometimes in patients where the light would fall at the edge, it gets reflected back into a crescentic problem, can give you dysphotopsias. So I'm just going to discuss briefly a case that happens, you know, dysphotopsias can happen under any circumstance to even the best of surgeons. I think the most important thing to understand, to take, you know, to understand over years of experience that is there on the panel here today, is that listening to the patient is half the problem solved. If you listen to the patient and accept the problem and, you know, acknowledge that there is a problem, then the patient is most often very accepting to it. There's no point in being defensive and saying, no, everything is good and lens is in place and you should just disregard it. When in doubt, it is best to wait it out, and repeated counseling is always best, because the one tool that we have in our hand, which is given by God, is neuroadaptation. So if you give enough time, you settle down with pretty much all the problems. The good news is it tends to resolve in most patients between 3 to 6 months. So there's no rush to jump into any sort of surgery or a YAG procedure. But it's very, very important also to be very careful in the other eye and to learn from your experience with the first eye and try to come up with the reason why the patient is having dysphotopsia. So this is just one case I'm going to discuss that we did in our clinic of a 62-year-old female patient who's had a good cataract surgery done elsewhere and has a pretty good technical outcome, if you talk in terms of technical outcomes. Good hydrophobic IOL implanted in the bag. But the patient is extremely bothered with negative dysphotopsia, so much so that it decided to jump ship and come to our clinic for a surgery. So the questions that were in our mind is, what should we do now with this patient? Going through literature, this publication from Dr. Sam Maskett shows that, you know, you can eliminate dysphotopsia, or you can reduce it in the other eye when the optic is laid over the anterior capsule, or rather by doing a reverse optic capture of the eye. This was a very interesting read. So we decided that we are going to attempt a reverse optic capture in this patient. What is reverse optic capture? You put an IOL in the bag, but you slip out the optics above the anterior capsule. So the haptic stays in the bag and the optics are in the anterior capsule. Again, we would understand a 3-piece lens would be a more suitable design. But because we counseled this patient, we decided to go ahead and we told the patient that dysphotopsia might still be persistent because it's a problem with their eye, and the patient decided to go ahead. Pre-operative screening revealed an astigmatism of 1.75, and so we shifted and decided to put a single-piece lens because we wanted to treat the astigmatism, because we didn't want that to become another deterrent in the patient's visual outcome. When doing a rexus, it's important, particularly so if you're planning an optic capture or a reverse capture, is to get the right sizing. And for about a 5.5 millimeter, if you can, would be a good size. So it's best to take all the time to make sure that you have a nice symmetrical capsular rexus, because the rexus will define the centration of the IOL as well, since you're going to capture the optic. So this is us taking all the time to create a good regular sized capsular rexus. Cataract surgery is unremarkable, but there goes a toric IOL in the capsular bag. Another good takeaway point is, whenever you plan to do any procedure that involves a little bit of manipulation, it's always good to have a good lens which has all the properties of intraoperative maneuverability and the comfort of being able to plant it in the right place and to be able to play with it Once the lens is in the bag, we remove the viscoelastic from behind the lens and dial the lens into its right axis. As you can see, it correlates with the topography kept up there. Once the lens is in the right axis, we now slip the optic. If you notice, the distal optic is being slipped out over the anterior capsule, and then the proximal optic. So it's good to take all the time possible, go slow. Good materials will, even if you dent these lenses while you're doing it, it sort of bounces back on its place, and these dents are not permanent on the IOL. It's important to make sure that the entire optic, as much as possible, is slipped out so the lens locks into place. And that's exactly what we're doing over here. And this is followed by a residual viscoelastic removal. Notice that the axis is right, the axis where it's intended to be. And this is a classical reverse optic capture with an intact posterior capsule. This is patient at post-op 6 months. Patient's happy, 6x6, IOP is maintained. The UVM shows the IOL is well fixated and is not rubbing against the iris as well. And the rexus margins are totally fused. So this patient is unlikely to develop a posterior capsule opacification as well. OCT is being followed up, and the retinal surgeon is obviously commenting on this, and it stays unremarkable. And same patient at 1 year follow-up is doing extremely well. So just to conclude, in our hands, reverse optic capture worked beautifully. It's a useful tool, particularly when we are doing the other eye in a patient who's already had negative dysphotopsia. But like Dr. Ramamurthy sir brought about, in an eye which already has a lens and has a dysphotopsia, maybe that brilliant idea of putting a sulcoflex lens of half a diopter may also save your day in that eye. Thank you.
Thanks a lot, Samresh. That was a very clear, crisp picture of dysphotopsia. I would want the opinion of the experts in the panel, Dr. Bhaival Savda, Dr. Suchi, anyone, Dr. Sandeep. Like, since this doesn't seem to be one way of dealing with negative dysphotopsia, so what do you all feel? Reverse optic capture is the solution? Like, as he said, if you've had a negative dysphotopsia in one eye, have all of us thought, or would we go back now and think of doing dealing with the second eye with a reverse optic capture, even if it's a toric IOL implant? Yes, Kamal?
One thing I've probably started doing for last 3-4 years is that I make sure that the haptic optic junction is within 0 to 30 degrees temporally. And there is an overlay of the haptic coming from the side. And I've been reading a lot of literature on this, and it seems to work. In fact, all my colleagues in SharpSight now, I've asked all of them to do that. And to my surprise, I don't think we are seeing many dysphotopsias now. So I think it probably works to a large extent.
Your optic haptic, what did you say?
The junction of the optic and haptics is supposed to be kept within 30 degrees, and there has to be an overlay of the haptic going across in the bag on the temporal side.
What are your thoughts?
0 to 180 degree. 0 to 180 degree.
It's a 0 to 180, but you see, I've seen till 30 degrees also. Sometimes the lens may rotate. It works great.
So because it blocks that rays on the nasal side. Yes.
The aberrant light rays which are coming in, because even on the opposite side, there is a haptic layer. It blocks the total internal refraction from a square edge. And then again, there is a optic-haptic junction. So there's no perfect square edge at any point on these sides.
So then again, the optic, placing the IOL horizontally, orientation of the haptic horizontally is definitely better than positioning it vertically. Yes, Dr. Sandeep?
Yeah, I just wanted to make one comment, that what Kamal said is very good, but that would work mainly in non-toric IOLs. What about with the rule astigmatism, where you're going to keep the lens at around, 90-70? So it's only against the rule or the non-toric that, you can have that flexibility. I just want to make one comment about this talk which Samresh gave. Haven't all of us seen that it rarely happens that the negative dysphotopsia occurs bilaterally? Samresh, I don't know what's your opinion. I generally find it is one of the eyes.
More so in the left eye, sir. More so in the left eye.
Mostly in the left eye.
More so in the left eye.
Correct. So if I were to do the right eye of such a patient, I would go ahead and do a normal procedure. And then if there is a negative dysphotopsia in the immediate post-op period, what Samresh has described is a beautiful idea. You can do it in the immediate post-op period also. Just capture the optic and, if the issue gets sorted out, it would be excellent. I don't know what is the opinion of the House about this.
There are-
Dr.
More
Abhay has something to add. Yes.
Yeah, I think there is a wonderful article coming up in March issue of iWorld by Jack Holiday and Nicole Pham. Please read that on negative dysphotopsia, various options. But if I have to do the second eye of the first eye having negative, I would simply try to do a larger rhexis. What is important is that if you have too much of an overlap of the anterior capsule, that sort of thing will occur. And I concur with, my friend that horizontal is the one that gives less. That's Kevin Miller's theory, which has a publication by somebody later on that placing horizontal reduces, but it doesn't guarantee that it will not happen. But it's a good idea, and Kamal, I do the same. So I think that's a great point you made it. But remember, if you have other eye, do a large rhexis, simple. Because reverse capturing single piece sometimes in some anatomy can produce an iris rub and produce a discomfort. So be careful about it. If you have to put, there's nothing wrong as you saw, but be cautious.
I think IOL exchange is not a solution for intractable dysphotopsia from what we understand from the talk now, that if it's early on, you can do a reverse optic capture. And if it is late on, like Dr. Ramurthy said, you could place a piggyback lens of a plano par. So these would be the ways. I don't think we need to look for doing an IOL exchange in any of these cases.
Right.
Yes, Ramurthy, you were saying something.
No, I just want to second what Sandeep said, in the sense that, very often you find that the dysphotopsia, negative dysphotopsia is confined to the patient in one eye alone. That particular case that I showed, where I put in a piggyback lens where the primary surgery had been done elsewhere with an excellent toric implant. And just because his negative dysphotopsia went away, he came to me for the second eye surgery. And since he needed a toric intraocular lens, the thought of creating a negative reverse optic capture came to my mind, but I went ahead and did a conventional surgery. And the patient had no negative dysphotopsia in the second eye. So it's not that most often we get it bilaterally. The patients often complain in one eye alone. And somebody just a question.
Can I add something? I have experience of 3-4 cases of the monofocal lenses, which 6-6 vision, and one eye was having very dysphotopsia, and eye trace, they show aberration, internal aberration. So that is because probably some capsular fibrosis, there was slight tilt in the monofocal lenses, and we just rotated that monofocal lenses and the complaint was resolved.
Yes, Dr. Kamal.
You see, as I've just heard the previous speaker speak, I do agree. I can show some videos where I've operated a patient. It's just 1.5 months down the line, and all I've done is just rotated the lens front and back, broken some adhesions, and maybe there was a slight capture of the capsule somewhere. It broke loose, and it has worked. So I've done this in 2 cases, yes. No optic capture, nothing, just broken the adhesions of the lens. The lens is still in the bag, but I could see there was slight kind of an adhesion, more so at one end of the anterior posterior capsule, just slightly pushing the lens or probably tilting it. And the Tracy did say something. So all I did, so I agree. What I did was just put some viscoelastic from 2 side ports and just move the lens, rotate, break the adhesions, and it disappeared.
I have done in 4 cases and all are resolved.
Before we go on to the next speaker, there's one point which was not covered. Of course, dysphotopsia doesn't need not talk on this. But what I wanted to know is what were your views on with the improvement in the multifocal IOL designs with a larger optic? Are we any of us still strict with the angle alpha component, or would that be covered by Dr. Naren Shetty in his talk?
To answer this, madam, we have to largely started not looking at angle alphas anymore. And unless and until, there is a big outlier, I would put my eye on that data, but I don't pay too much attention to angle alphas, particularly with the newer panoptics and the BBT lenses. I don't really look at them.
Yes.
Yeah, definitely, ma'am. I think, see, the chances of that happening or having a large angle alpha is extremely, extremely rare. That is why a lot of practices happen without doing it, and they still, 99% of the cases, everything is perfect. It's just that 1% rarely which occurs, then you can land in a suit. But with EDOF lenses are much more, forgiving, even larger angle kappa, they still okay, they still do well. So
good. So we shall now go on to our next speaker, Dr. Haripriya, who's the Chief of Intraocular Lens and Cataract Services at Aravind Eye Hospital, Chennai, and an amazingly prolific surgeon. And then she is going to definitely have a lot to tell us on capsular bag challenges. And on to you, Dr. Haripriya.
Thanks, Dr. Chitra. Are my slides visible?
Yeah.
Thank you. So I'll be talking on capsular bag complications. So in the postoperative period, I think the most common capsular bag complication one would encounter is posterior capsular opacification, and this could be related either to the technique per se. Obviously, we see less of this when we do a phacoemulsification to have the lens in the bag, and the IOL design as well. So in instances where we have a square edge lens, posterior edge, that would help to create a shrink wrap, and thus reduce the chance of lens epithelial cell migration and therefore PCO. So to an extent, the technique and the lens design could help, but where the patients do have a PCO in spite of it, the good news is it's easy to treat. The bigger problem would obviously be access to a facility which has these.
Could everybody please be mute themselves so that we can have an undisturbed talk?
So access is one challenge which can be there, especially if you're doing for patients in the periphery and the suburbs. The other aspect will be the capsular bag distension syndrome. The other complication could be capsular bag contraction and capsular bag IOL complex decentration or dislocation, which could either be because of pre-existing zonular weakness or because of compromise during the surgery of either the capsule or the zonal apparatus. So capsular bag distension syndrome is seen typically in patients who have received a capsular rhexis, and the rhexis covers the edge of the optic. Now, this is a very rare complication, probably seen more in high myopes with axial length more than 25 millimeters, and sometimes in patients who receive 4 haptic IOLs. Again, the good news is when the patients do come to us with defective vision, the good news is it's easy to diagnose and to treat. So doing a YAG capsulotomy, the patient has immediate relief, and more so over the next 2 or 3 days once the lens matter in the anterior vitreous gets absorbed. Capsular bag contraction is something which we would see, especially in patients who are more prone to it, like patients with retinitis pigmentosa or pseudoexfoliation or ectopia lentis. Also in patients who receive a smaller capsular rhexis, especially in patients with pseudoexfoliation where one tries to avoid making a large rhexis for fear of extension. So those patients also have a small rhexis, which again increases the chance of capsular bag contraction. And again, these patients, if identified earlier, it's easier to YAG the phimosis and release it. Interestingly, in patients with retinitis pigmentosa have a very high risk of anterior capsular contraction. And we also have seen complete capsular, anti-capsular contraction in patients with RP, even at the first month follow-up. So again, it's important to remember to make a slightly larger rhexis. But if one does not do it, at least end of surgery before aspirating the viscoelastic, one can just take in the vanas and relax the rhexis margin so that you prevent the contraction forces, which would also reduce the chance of further zonular damage and IOL decentration. In these instances as well, a YAG could be done to release the phimosis. Moving on to patients with IOL decentration. So this is a patient again with pseudoexfoliation. A couple of years later, the patient comes with a capsular, with an IOL decentration with a Sommerings ring. And the capsular bag is also loose here. The IOL is not in the capsular bag, and there's a lot of lens matter here. So the first option obviously would be to try to refixate the same lens. In this case, because there was a lot of lens matter, I prefer to explant this IOL and place another IOL. So while doing it, 2 instruments could be used, 2 Sinskey hooks to dial the IOL capsular bag complex into the anterior chamber, grab the optic haptic junction. That way you'll ensure the haptic doesn't get stuck in the tunnel, and remove the lens with the capsular bag complex. So we can see the patient has pseudo exfoliation material on the pupil. So for a secondary IOL, which either technique, either a serial fixated iris claw, whichever the surgeon prefers, one can adopt. Here I'm doing an iris sutured lens, which is my primary choice of lens. So I'm using a 10-0 Prolene suture, taking using the same suture needle. I make 2 bites exactly opposite, each bite about 2 millimeters long, and retract the loop from below the iris, bring it out through the main tunnel, and have this looped at least twice over the leading haptic. So the right loop goes around the leading haptic. Now this is a large tunnel. So I've made this large because the primary IOL was a rigid lens, so I could not cut it. So I use a rigid lens here. And the trailing haptic also is looped with the same suture on the left side. And the IOL is placed in sulcus, which is which is now dangling with the help of the suture. So both the sutures in the anterior chamber, the end is then extruded, and then the knot is tied so that the IOL is thus stable. This other case, the IOL is well centered, but this patient has a toric lens and has a refractive surprise. So this patients need a IOL explantation, IOL exchange. Now, and a concern could be the additions. Now, this patient had surgery. If it's within 2 to 3 weeks maximum, the hydrophobic lenses are easy to remove. If it's beyond that, one will have to use viscoelastic, use a spatula, or use visco below the rexus margin, use 2 instruments and reduce the synicate. So you have additions either between the anticapsule rim and the optic, or more dangerous if you have it between the haptic and the capsular bag equator. So here 2 instruments are used to bring the IOL into the anterior chamber. IOL is grabbed using a micro forceps, and then the IOL is cut into 2 halves. If one does not have the micro grabbers, one can consider holding on to the haptic. So the haptic, which is externalized, can be held tight, and this can also help bring the optic more anteriorly and stabilized. And then use your vernas or your micro scissors to cut the IOL into 2 and then explant the lens. So if one is planning an IOL repositioning or an IOL exchange, the hydrophobic lens, I think it's better to do it within 15 days. That is ideal, but even if it's after a month or 2, it's not bad. But anything beyond that, one may have to amputate the edge of the haptic adherent to the capsular bag to prevent any further zonular loss. Here the capsular bag is intact, so the new toric IOL then goes into the bag and placed on axis as per the plan. This other case again is a lens which is decentered here. The reason it is decentered, the patient had a PC rent, and the surgeon had planned to place it in the sulcus. However, the IOL was placed in the bag, and since it was an inferior capsular tear, the IOL is decentered and was decentered inferiorly. So here the option is to place it in the sulcus because there is adequate capsular support all around, and the haptics are also PMMA. The same lens can be used. So to ensure the haptic is stable on the capsule, the Coughlin's hook is used to retract the iris. One can also use iris hooks or use the Coughlin's hook to retract the iris and then dial to ensure the IOL is stable. So this is a patient who had a surgical complication, but because of improper placement during surgery, these lenses decenter. This other case again is decentered, again a patient with a PCR. So the first goal obviously is to try to center the same lens using the existing capsular support. However, the capsular support is not much. There is no PC support, and the anterior capsule rim is also less than 5 clock hours. So this is not going to center. So one, in this case, one may either choose to, refixate the same lens or exchange. Refixating is easier if the refractive outcome is good because then you don't have to have the extra manipulation maneuvering. So using a 10-0 Prolene suture needle, knowing where the haptic is placed, a suture bite is taken, including the haptic and the iris. Once this is done through this common side port, both the suture ends in the anterior chamber are retracted out through a modified mechanical suture. The knot is tied such that the haptic is now fixed to the posterior side of the iris. So I place about 6 to 7 knots here, and this helps to secure the haptics well. So this is a technique which is fairly easy to do. The only challenge would be it may seem like a blind procedure. So before I take the bite, I would retract the iris using a Krugland's hook, identify where the haptic would be, and then take the bite. And while I take the bite, I look if the optic is also tilting, which ensures that the bite has also included the haptic while it is. So you can see the lens is also tilting, which means the suture needle has included the haptic while the bite is being taken. The second haptic is also secured in a similar fashion because there is only less than 5 to 6 clock hour anti-capsule support here. So instead of risking a decentration or tilting, both the haptics are fixated to the iris. So in conclusion, to reduce postoperative capsular bag complications and IOL decentrations because of a compromise in capsular bag, I think some things which we can do is to ensure the capsular excess is large enough, especially in eyes with weak zonules, to prevent capsular contraction. Again, if the patient does have a PC rent, ensure the IOL is placed in sulcus. A 3-piece design would be better, but if the support is inadequate, better in the primary surgery itself to fixate it to either the iris or the sclera. One can consider using a CTR or modified CTR if you're not sure about the capsular bag stability, either because of a preoperative or an intraoperative zonular lysis. In patients where we have higher risk of PCO, then it's also good to ensure we have an annual follow-up so we can treat the patient when the vision reduces. Thank you.
That was a wonderful talk, Haripriya, and so many videos with take-home points that most of my questions are answered, rather for the attendees too. But if there is a case of a high myope and there is, PCO tends to be quite challenging in these cases. So what are the intra-op measures and what would be your post-op measure to preventing PCO, or as brief as?
Yeah, so I think one thing during surgery is to try to do, routinely also I do a wash of any residual lens epithelial cells, so any fibers you have. So I would like to wash that in myopes, again, in all cases as well, but more so in myopes because you want to either prevent or delay a PCO. That's the only modification I would think of. And a 3-piece lens is what we would do in high myopes, which is, again, many papers have shown that 3-piece IOLs have a better chance of delaying PCO than a single-piece design. Post-operatively, if the patient does present with a PCO, I would normally get a clearance from the VR colleague to look for any peripheral lesions which require any barrage or laser to be done before a YAG is to be done. So I would not take it directly for a YAG capsulotomy.
Would you look for a PVD and feel it safer to do a YAG in these patients?
That is true, yes. That's another factor which would also help us.
Dr. Suchi, I wanted to ask you, if it's a severe capsule phimosis with zonular weakness, how would you approach this case? Can we have an entire panel view, Mr. Sharik?
It's already there, ma'am.
Oh, sorry, it's not there for me. Okay, fine. Dr. Sufekci, I wanted to ask you, a severe capsular bag phimosis and there is zonular weakness also. What would you suggest? Would you say that we remove the entire bag, or you would have some novel way of doing things?
Okay, so I really think it's important to decide whether you want to preserve that lens. So if it's a multifocal lens and the fellow eye has already a multifocal lens and the patient says, can you please try to save my lens? Yeah. Then I've gone to the extent of hooking up the bag and then trying to dissect free the subcapsular fibrosis, by separating with toothed and non-toothed instruments to peel off the subcapsular fibrosis. And once you find the plane, actually, it's not that difficult to actually start to slowly tease away all that fibrotic tissue that's causing the phimosis. And if you really find it's really adherent, then you can just cut with scissors so that it does not rip out. And once you've done that, then I put in a CTR, and as necessary, I put in capsular tension segments to fixate with Gore-Tex sutures to the sclera. But if, that's just a monofocal lens and the patient doesn't mind having that change, then my preferred technique is to explant completely, do an adequate vitrectomy, and then do a Yamani fixation, because I think that gives a really secure anchoring of that lens. And it's really a very stable outcome.
Do you believe that in a high myope and a toric IOL, placing a CTR makes sense, or it is just a theoretical talk?
I do that, if I want to preserve a toric lens and a high myope, trying to avoid going into the vitreous, to do gel removal. So yes, I would try to avoid, those extra maneuvers to protect the retina. So I would try to preserve the lens and the lens bag then in such patients.
Dr. Haripriya told us a very good point that, if it's a RP case or an eye with severe pseudo-exfoliation, making those nicks on the anterior capsule during surgery would be one solution of sort. How many of us do that actually? Yes, Kamal?
I do that regularly. And in case I'm not going to do a nick sometimes in the rexes, because most of these pupils may not be very large, I make sure I put in a CTR in these situations, because that further delays the situation for me. But in case I have a big dilated pupil, I probably go in for a larger rexis. That also reduces the incidence. And I give three cuts at 90 degrees each. 3 cuts on the rexis, small little rexis, and it does the job.
Good. I think Ramurthy, you have anything to add? Oh, yes, Dr. Nath. Yes,
whatever I said on the retinitis pigmentosa is correct, but even without the fibrosis of the anterior epithelial cells and capsule, they can have a late decentration, because RP patients, irrespective of the pool on the zonule because of the small pupil and phimosis, they can have a zonulopathy and have a late decentration with a decent rexis size and no evident phimosis. So RP patients are at a risk, and they need a counseling, and this is the session of the counseling. So we need to tell these patients and follow that up for a long, long time.
Yes.
Yes, Dr. We actually did.
Yes, please go ahead.
Yes.
Yeah, so we actually did a study to compare 2 groups in patients with retinitis pigmentosa who received and did not receive a CTR to look at did that help reduce the risk of phimosis, and we found actually it did not. That was something which we also, the pseudo-exfoliation study, which we are almost about to complete, which included patients without pre-op phacodonosis, without intraopsonular loss, and where we again randomized them to with and without CTR. We did not find a difference in terms of capsular phimosis or PCO being different. But anyway, I mean, if you're having any doubt, like most of these RP patients during surgery itself, you do find some zonular weakness. So in those cases, I think it makes sense. But prophylactically using a CTR, we found did not actually have a big role.
Yes, Dr. Ajay?
I just wanted to ask Haripriya, I think that's a wonderful technique that you fixed the lens in the iris, but I just have a concern. Excepting the sensor lens, almost all lenses, sensor has an anterior curved surface, anterior curvature, but the margins, but about this, especially the Alcon Acrisoft and many other lenses, they could be rubbing in the long, because you have done quite a few cases. So what is your long-term,
so
is there any pigment dispersion?
So normally for sulcus fixation placement, I always prefer the sensor lens. I don't.
No, about these lenses that you relocate the lenses that are already there.
Yeah, so if it's a BMMA lens, it's a rounded anterior edge, so there is no issue. If it is a single piece lens, I don't do iris fixation. I only iris fixate a 3-piece. If it's a Alcon 3-piece lens which has been already placed, I would still go ahead and fixate, because we find that even if you're fixating, the optic doesn't actually go and touch your iris. So we don't see a higher incidence of CME or pigment. Of course, you can because of the manipulation, but it's not much higher than or what you would expect of other of an iris fixation technique. So it does sit a little more posteriorly, where you would normally, where your sulcus placement lenses would normally be seated.
Yes.
Just a couple of tips for any youngsters who are listening in. One is this, whenever there's a greater tendency for capsular phimosis, or sometimes even if you ended up with a small rhexis and you're not confident enough to enlarge it, nicking the margin of the rhexis is a good idea. But please don't overinflate the bag once, or the anterior chamber once you have nicked the rhexis, because that sometimes makes the rhexis run around. So you have to leave the eye a little soft. And the second thing is, in case you have a capsular bag distension, then when you are talking about a capsulotomy, you don't have to really puncture the posterior capsule. Just nicking the rhexis margin where it overlaps onto the optics of the lens, that itself might suffice to relieve the capsular distension and the lens might settle down.
Yes. Yes, Dr. Sandeep, before we go on to our next speaker.
Yeah, just one final thing which I found useful. Suppose I've done a case and it's a high-risk case for capsular contracture. One other thing that you can do besides nicking the anterior capsule is to clean the anterior subcapsular epithelium all around, 360 degrees, starting from the rim. And I've seen in all these cases that capsular contraction incidence is very low if you manage to clean most of the anterior subcapsular epithelial cells.
In this particular group, otherwise routinely doing a polish is not needed. But yes, in this subset of cases, and that's a great discussion. And Haripriya, please do stay on right till the end. We want your inputs. And we shall now go on to our next speaker, Dr. Ajay Paul, who needs no introduction. Again, a very good friend of mine, is the director of the BBI Foundation Group of Hospitals in Calcutta. And yes, an amazing, astute, prolific surgeon. And he's going to show us some truly amazing surgical acrobatics with iris deficiency in cataract surgery.
Thank you, Dr. Chitra and team ARC AIOS for having me in this August gathering and to present a few of those cases. So I'll be speaking on iris deficiency associated with cataract surgery. Now the iris, it regulates the amount of light by changing the diameter and the size of the pupil. So it gives us good quality of vision, reduces aberrations, and reduces that excessive light that can go and cause glare, and decreasing the depth of focus, and cosmetic concern is also there for the iris is concerned. Now, when you come to these conditions, basically they are congenital and acquired in a clinical condition which they come to us, and iridia is one. You might meet it once or maybe in your whole practice life, very few cases. Coloboma is something that you meet quite often. Ocular albinism is, again, you could meet it, but the acquired ones were the ones which you practice. My 25 years of practice, I've definitely met quite a lot of them. Iridodialysis, mydriasis, the iris tear in a penetrating trauma, iatrogenic or iridectomy, and post-uveitis, you may have all sorts of pupillary size and post-drug response, especially after TAS. If TAS, you can end up with a dilated pupil which doesn't go down. So the restoration and the size of the function depends on whether you can do it on the ocular surface. It could be a cosmetic contact lens in the early stages. A corneal plane level, you can do corneal tattooing or intracorneal stromal implants. Well, these are not easily clinically practiced as much, but what is more important is the iris plane, where you could do the suturing or you could put these PIDs or prosthetic iris devices. Non-surgical management before the cataract sets in, you could try out tinted glasses or fluoride patches, tinted contact lenses, artificial pupil contact lenses, but then they are the ones you are biding your time till the cataract sets in or the patient is visually handicapped by the cataract that is coming. So the surgical planning is basically the sutures. One can use those, repair those small defects of the iris, the artificial iris implants. For the larger defects, modified capsular tension rings. Now these are the iris reconstruction lenses and the rollable silicone wafers. So this has not been available to us clinically. I don't know whether any of us have done it. Well, there are three basic companies, European companies, basically Morcher, Optec, and Human Optics. We got the Care Group, which manufactures this for us here. I have no financial interest in that, but whatever devices we have used is the Care Group people. So these are the coloboma lenses. The one we get here is around 5.5 millimeter optic. Now this also remains bigger, but then you get the Morcher ones, which are smaller in size also, the multi-segment and anivida rings, and of course the anivida segments. Now these are the ones which are there in the literature, in the artist and the iris reconstructive IOLs, where you can, we can put a CTR and the color of the iris can be matched, and you can match the size of the pupil along with that. But let's come to the ones, the iridodialysis repair, which you might meet it quite often. And these are the suture techniques. Now, this is a, as you can see, there is an iridodialysis here. I'll be doing the railroad technique, and later on, I'll be showing a single pass 4-throw technique. You can end up with an updrawn pupil at the end of the surgery. Here, I'm using the iris hook to get me the area for I do the emulsification. It's a routine emulsification that goes on. And as I go forward, I finished it, I put in the lens, and then I would see tap the iris and see what size it gets. Is it the right size? And then tapping it, getting into the central area. And then it's very important that you take that bite here. I'm doing a 2 millimeter away from the limbus, a small scleral groove. You can use the scleral flaps, or you can use the Hoffman's pocket here. A straight needle, a 9-choline, that's what I use. Take a bite and be careful that you don't take it too much into the body of the iris, so that the iris will be pulled too much away. So it should be just enough to get you the bite, but at the same time, it should not be too periphery, so that there is the cheese wearing where the iris tears off, where the suture is tied and the knot is tied there, and then you can tap it and get it to the right size. Many times, as I said, it could be the denervation of the iris can lead to a bit of overwhelm in refractive people, but you can put it with those forceps and get it to the right size. The next case I'll be showing is iatrogenic. Now, this was a patient which was referred to us who had a foldable lens in the anterior chamber. It stayed there for almost a year before the patient developed a lot of irritation, inflammation and cornea. And once you tried to put it, the whole iris did not. This could happen even when a beginner does an SICS, the whole black nucleus, you can get the whole iris out. In this case, we tried to disengage that lens there. And as we did that, we put in visco and tried to position the iris there. See, the iris is almost this insertion, almost 270 degrees, almost this part, and just we put in some air and visco, left it like that. And after 1 month, we took up this case. There was a lot of inflammation, the inflammatory, membranes were there. We did a vitrectomy, and since this was quite a lot of area that had come out, it had already adhered here. So the main, you can see this is already adherent here. So we went ahead with the railroad technique there. We took one bite there and there, took it out, and continued with the second iridolized insertion there, and continued it there. Once we got it there, we finished up with the vitrectomy and putting an SFIR in this. So it's very important how you place those iris towards the sclera and attach it there. Now, this is a case. We've done a subluxated lens, a traumatic subluxated. You can see all the Sioni ring is there. This was a femtosubluxated, and then we wanted to get that iris the right size. Now, this is the single pass 4-throw technique where you can get the iris without going on the macrolin suture or going inside the eye. So this is where you get that loop out. This is so popularized by Dr. Amar Agarwal. As you can see, 1, 2, 3, 4. You can get that 4 knots and then get it the iris. And then you assess how much do you need one more suture. In this case, we went to the second suture there to get this iris right in the center, the pupil right in the center. Once you got it there, the second knot there, and then use it. Then you see the knot there, the 4th row, and got it in the center. And then assess the size of the pupil. As it dried, use that forceps to pull it up, and we got it. So we found that this is quite central, it's round. So we just completed with the 3rd knot there. Once we finished this and the surgery, we just had a nice round pupil. Now, this is a mydriatic pupil, which we have done a traumatic subluxated cataract, and this was an atrophic iris. As you can see, this is the first string pupilloplasty technique. This will go one side and then put it round, 2nd, 3rd, 4th, and most of the time they are non-reactive, end up in a stellate form. And it should be careful not to pull it too much. There could be cheese wearing, and the sphincter of the pupil is too small. And in this case, as you can see, we had to add few more sutures to it, and then we got stellate appearance, but actually that got the patient rid of the photophobia that's attached to it. And now this was a case of iridodysgenesis syndrome. Now these cases normally you would not be successful doing this, the technique of suturing the iris, because these are quite well apart, as we learned in this case. And at the end of the case, we just tried to suture the iris, and there was a cheese wearing because you could not afford it. But in these sort of cases, what you need is the aniridia segments. We will come to the next segment. Now, these are the cases which need anaria or coloboma segments, where you get different sizes. Now, this patient is waiting for the second stage of the surgery. The anirias, we have ordered it and we'll be getting it very soon. Now, the multi-segmented aniridia rings are another things. Now, this is a case where you can see this is where you do a capsular excess just around 4.5 to 5 millimeter, and these multi-segmented ones, you do the phacoemulsification and increase the incision, because you cannot do it with this almost 3.5 to 4 millimeter incision. This is the first ring going in, and you can just maneuver it. Right, and you need to use a high molecular viscoelastic. These are actually very brittle. One has to be very careful getting that, and the incision should be a bit more than what you would do, because this needs at least 3.5 millimeter, but the 4 millimeter is what you can be comfortable. Once this is there, you've got the ring in the bag. The second ring goes in behind it. One has to be very careful while maneuvering it into the bag. Once you've got it there, the bimanual way, put the bag, put the lens, put that ring in the bag. And the only minus point is that you ultimately get around 6 millimeter pupil here. The glare might still remain, but that's the best you can do if you want to put it right into the bag. And this is the last case where we are showing. This was again a iatrogenic. The iris had gone. This was referred to us. You can see a small belt of iris left there. This was the original incision and ascites. So these, you can see the aniridia IOLs. They are actually around 8.75. So actually need around 9 millimeter incisions, and the optic is around 5.5 millimeters. We need a bigger incision. This is what we are doing in a temporarily, and then open it up. Put the lens there. See, the lens is on. There's an addition of the iris that is there. We just cleaned it, and you've got a nice the capsular rim which is there. The lens is maneuvered, goes behind that little bit of iris strip. And these are generally, you can, if you put it in the FAQ also, you can use it as SFIOL. But most of these lenses in the long term can, these eyes can be glaucomatous. So the ultimate answer in these would be the customized artificial irises. You can roll it and put it inside. Well, I have no clinical experience with this. I know some panelists might be having. These are the artificial irises with fibers and without fiber, where you have got, you can adhere it, you can tie it up in the sclera, and just like any other devices that we are using, scleral fixation. So to end, patients with congenital and acquired defects of the iris are challenging. Caring of this patient is very gratifying, and they're usually appreciative of any improvement that is there. And so you may not meet in daily practice, but once you have, one has to be right on the topic and the right instrument and the right techniques to use to implant this and do this iris suture. Thank you for your patience here.
Thank you very much, Dr. Ajay. That was amazing and a wonderful selection of videos. I think it has been a real learning for all of us. I have a question for you. Like, supposing you have done a pinhole pupilloplasty and the pupil actually becomes very small, and this patient needs a later retinal evaluation. Have any of you all had an experience that you have? What have you all done? Would you have done a YAG laser suturolysis of this thing, or how have you dealt with such a situation?
So I have not, as you said, I've left it around 1.5 or 2 millimeter, the cases. I do not, the pinhole pupilloplasty for different like keratoconus or high astigmatism, I have no experience in. But then I think that's the only way where if you want to see the periphery, if you have a retinal problem, doing a sphincterolysis or going by the side port and using micro scissor opening it up if you have to see. But that's the only negative point. I mean, when you have those pinhole, very small pupil. But then if you are left living at 1.5 to 2 millimeter pupil, I think you can see the retina quite well.
Dr. Sufekchi, if you have a traumatic iridodialysis and also a lax capsular bag, and which actually it's large, that you need a CTS to be placed, would you be daring to do both in the same sitting, or would you take care of the capsular bag and IOL and later consider taking care of the iridodialysis?
Thanks for your question. I've had a patient who had both dialysis as well, iridodialysis as well as zonulysis. And, in fact, when you're dealing with a cataract, that's the best time to deal with the iris issue. Because if you have an intact bag without the zonules, you can still do a capsulorhexis and implant the lens, the artificial iris, into the capsular bag with the IOL. And then I put in the CTR and the CTS. And with the CTS, I anchor that to the sclera. So that actually means that the implant is inside the capsular bag and you get less risk of glaucoma and other issues. Whereas if you dealt with it, secondarily, you would have to suture that artificial iris directly to the sclera, and the patient has a higher risk of glaucoma.
Okay. And what would be the tip for a beginner surgeon to prevent iris tears when you are taking a bite into the iris? Dr. Ajay, would you tell?
Yeah, I have shown that you use a forceps. I mean, instead of doing it blindly, use a micro forceps, hold it and a bit away from the margin. I mean, you should have enough of the, or else many times, or if you're taking a 26 gauge needle, you just put it in the opposite side and then go it just the right side. I mean, it may be trial and error till you get the right amount, and the eye has to be steady and you can hold it and get it. One has to be very careful. You don't do it too much posterior, so that you'll make the bump there sort of, or you make it too periphery that you do a cheesing off or the tearing of the iris.
Yes, Dr. Kamal?
I think I agree with Dr. Ajay. I've been doing it with 26 gauge needle also, but I've realized over time that, it tends to leave a big hole there when you do the railroad technique and, you go through the needle with the 26 gauge. So what I've started doing recently is I've started using the ILM peeling forceps of my retina team. And it works amazing, just a small little side port and the forceps, ILM peeling forceps goes, and it has a very small hole. It doesn't damage the iris. And I just hold it where I want the needle to pass through, and just hold it with the forceps, and I go with the needle next to it, and I can repair the iris very well with that. So I don't have large gaping holes or atrophic patches in the iris.
Just a small tip, fantastic presentation, Ajay, but just to add to what you said, what both you and Kamal said, using a forceps and holding the iris gently gives you more control. But instead of passing the 26 gauge needle, if you're using a 90 needle, keep the 26 gauge needle outside the iris, pass the 90 needle through the straight needle through the iris, and then do the railroading. You find that the larger bore of the 26 gauge tends to cause more iris damage.
That's more of a support. I mean, put the 26 gauge, take the needle and take it on that, and then slide it through. Because once it comes out through the opposite, you might lose balance, and then something there, and there's a support sort of. And that's what we do in an SFLR, just pass it through, and that acts as a support. Especially when you're trying to maneuver those long needles. I mean, if it is eye where the nose is obstructing, so that
in a deep set eye, it can be very, very big problem. In a deep set eye, you do need a 26 gauge needle.
Yeah.
We have more speakers, so I think yes, Susan.
First of all, let me just say I did join in the beginning, but then there was another meeting, the AIOS meeting itself, which I had to, and then so I joined back now. I didn't attend the entire discussion that just happened, but I think that it's about the opening that can come on the iris when you do the pupiloplasty. I don't know whether it's already been mentioned, but a 30 gauge needle does decrease that the incidence of that happening a lot. So we have completely stopped using 26 gauge. We have been using only 30 gauge. And even with that, a little bit of movement or a little bit of excess pulling or traction when you do it can cause a hole within atrophic iris, especially not in healthy normal iris, but in atrophic iris that can happen. So 30 gauge needle is much more useful. And like Dr. Kamal said, also forceps can also sometimes help in just decreasing that hole from happening. One of the most important things is how you maneuver it. So actually these are supposed to be done with curved needles, but since we don't have curved needles, we all do it with the straight needles. The curved needles gives you a much better way of being able to hold it. So in a worst case situation where let's say the eye is very deep or something, you can actually curve it out just with your hand a little bit and then
Absolutely.
use it. So we go on to our next star speaker, Dr. Chi Soon Faik, and she's going to take us through again amazing set of videos in late in the bag IOL dislocation management options. On to you, doctor.
Thank you, Chitra, for inviting me. So let's go to some videos now. These are my financial disclosures. So there are many management options, and in this patient here, I'm just going to recycle this IOL. The lens is dislocated within the capsular bag. As you can see here, it's dangling into the vitreous cavity. And from clinical examination, I've recorded exactly where I can find it. And iris hooks help to expose where I can grasp the IOL without grasping any vitreous. And it's very important how you handle the vitreous when you bring the lens up. So in this case, I'm doing dissociated vitrectomy, 23 gauge coming in from the limbus. And I strip the capsular bag because I'm going to iris fixate this 3-piece IOL. And I release the hooks with one hand by pushing the hook towards the center of the eye and then lifting it up and myousing the pupil with 2 pericenteses. I then pass this curved PC7 needle. All right, it's a 10O polypropylene. You can use 9O polypropylene. And this goes round the haptics behind. And then once I've got 3 passes done with a seamless sliding knot, I make sure the IOL is centered before I tighten on that suture and then do 3 1-1 knots and then push the optic gently back. And then we have a nice round pupil, and I do that peripheral iridotomy, which is very important to prevent a pupil block and optic capture. Now, this patient has got retinitis pigmentosa, and I myself did the cataract surgery with a single-piece lens. I did not use a capsular tension ring at that time of surgery, and you can see his whole lens is beginning to decenter, and I'm going to fixate this using Gore-Tex suture. So this is a single-piece acrylic IOL within the capsular bag, and this is using Gore-Tex 7O suture, which is also known as CV8, pre-threaded in this 26 or 27 gauge needle, which you can use through the Hoffman pocket, going 2 mm posterior to the limbus. And I use that as a suture snare. So I extend that loop of suture, which I threaded, and I use that to retrieve a short length of free Gore-Tex suture. Again, this is the suture snare going behind the haptic through the capsular bag. Retrieve that loop out to act as a lasso to bring in a short free segment of Gore-Tex suture to the Hoffman fixation point, and then using the suture snare now to pass above the haptic, and the other end of the suture then is brought to the Hoffman pocket. We then retrieve the sutures through the Hoffman pocket using a Sinskey hook, and we do this for the other side. So it's important that these 2 points of fixation are diametrically opposite and equidistant from the limbus, so it's usually 2 mm, and then I tie the 2-1-1, okay, so because it's a bulky knot, and then it slips into the pocket. Now this patient is a very high myope and has a dislocated single-piece PMMA lens, and you can see it's a very big optic, so I decided not to remove it. So I did some limited vitrectomy so that where my sutures pass, I'm not going to catch vitreous. This is using Calabrava's technique with a suture round like a belt loop. So one behind the other, 2 mm posterior to the limbus, and this is 6O polypropylene, one going from behind the haptic and the other going above, and we're doing this for the same thing, diametrically opposite, just passing a short segment of 6O polypropylene into this free 27 gauge needle that has passed through the capsular bag behind the haptic, and then the other end of the suture passes above the haptic. And so the lens is still within the capsular bag. And we then do the peripheral iridotomy again, which I think is a very important step. And then we flange down the two ends of the suture after tightening it and making sure that it's buried deep within the conjunctiva. So this patient has a toric LL, which is dislocated, but the other side of the zonules are still intact. And so we're going to preserve this lens. So I first mark the axis that this lens should be sutured to. I then support the capsular bag. So with these hooks, I ensure that the toric alignment is appropriate. I even able to open up the capsular bag and remove some of the old lens material. I'm now going to insert a capsular tension segment. Right, this is 5 mm, in the extent of the arc. So it's important to open up the capsular bag wide enough. And if you are unable to do that, then you can't use this, but you can use an RC anchor, which is far narrower. So again, with the suture snare, we extend the lasso loop out of the eye, thread the end of the suture that is bored by the capsular tension segment through it, and bring it to the scleral fixation point through the Hoffman pocket, and repeat this for the other end of the suture on the capsular tension segment. And then we retrieve the sutures from the Hoffman pocket, and we tie 2-1-1 knot, adjusting the tension to suture to center the LL. So you need to always tighten a little more. Now this is the last case, and in this case, I'm not going to recycle the lens. I'm going to exchange this lens. It's a 3-piece LL, but I'm going to use the Canabrava technique, the Yamani technique, which is really my preferred and go-to technique in these eyes. So you can see here a 3-piece LL, which I retrieved, and we're going to cut it and then explant it, having fluid running in the eye and some dispersive viscoelastic to protect the cornea. After doing vitrectomy, I then AIOS the pupil, implant this 3-piece sensor lens into the anterior chamber, and make sure that the pressure at the back is adequate. So I feel some BSS posteriorly so that the lens is in a good plane that I can reach, going 2 mm from that pre-marked point, which is again 2 mm from the limbus, which is diametrically opposite. I pass the 27 gauge needle, which is bent, and then I repeat this for the diametrically opposite side to retrieve the haptic. So you can see the haptic being pushed into the bevel of this needle. It's important to try to maintain the lens position and not overextend this haptic, which can sometimes kink because this is a PMMA haptic. Of course, if you have PVDF haptics, that would be preferred. And then you flange either end, and you flange it to a similar extent. So I normally grasp where I want to flange it down to. And before you push in the flanges, you just check to ensure that you're happy with the lens position, it's not tilted and it's well centered. You then push this into the beginning of the scleral tunnel. Don't push too hard. I've actually pushed it right in. All right. And then you have the peripheral iridectomy there, and you have a very well centered and secure lens. So in summary, it's important to ensure that you can retrieve the LL in subluxated lenses, and you can clear vitreous safely, and diluted triamcinolone always helps to visualize vitreous so that you remove every strand. And when you grasp the LL, do not pull on the lens until you have cut the vitreous around. And then the easiest technique, which I showed you, really is iris suturing, like Dr. Hari Priya has also shown you. But the technique that I prefer today is really an intrascleral haptic fixation because it is so secure. And it's the technique that I would definitely use. If you have various techniques up your sleeve, then I would use the intrascleral technique whenever you're dealing with a post-vitrectomy eye, because there's no vitreous to support the lens, and there's really a lot of donosis of the LL. If you failed at iris fixation, I do not redo it, especially if the iris has been traumatized before. And I prefer generally the flanged LL if you've got a very large white to white, more than 13 mm, rather than using a glued LL technique. And also the flanged LL is really preferred if you have to spare the conjunctiva in cases that are having glaucoma that may require surgery. Thank you very much.
Thanks a lot. That was wonderful as usual, amazing. And we saw all surgeries which we can learn to do or which we'll never learn to do. So, and that was a simple question for all of us. Like in cases where there's a possibility of a progressive zonular weakness, like in pseudo-exfoliation, have many of us started doing placing IOL in the sulcus with the CTR in the bag and doing an optic capture. Would you suggest that we should be handling those kind of cases like that?
Generally, for me, I still place it in the capsular bag, and very often it's because I use a toric lens. So, you know, I don't consider offering the patient a 3-piece lens in the sulcus, but of course we warn the patient that, you know, over time this lens may decenter, and I usually do implant a capsular tension ring at the time. It makes it easier to dissect out the bag should I want to put in a capsular tension segment to preserve that toric lens.
Yes. Any other thoughts among the expert panel? Have you all ever thought that earlier days where we used to do a can opener, the possibilities of capsular phimosis was much less those days? Or now that we understand how important it is to have that ideal capsule wrap, it is maybe it's a redundant discussion altogether. No thoughts? No comments?
Yeah, I do have something, ma'am. I just wanted to just discuss about what you just said. About, you know, in pseudo exfoliation or basically progressive causes of subluxation, where you can where you give the option of putting the IOL in the sulcus and then doing a capture and with a CTR in the bag. The point that I see in that approach is that the IOL is still going to be partly supported by the bag, and the entire bag CTR complex can still subluxate because the subluxation is a progressive cause, and therefore the IOL may also subluxate with time. I don't think that because it's also captured. So I don't know how that is going to actually prevent long-term subluxation. So what I do in these cases, and that's also something that I've published, is the supracapsular glued IOL fixation. So what you can do in those cases is, even when you're doing the I wouldn't suggest it, of course, for mild pseudo exfoliations and things like that, where you would just put a CTR. But for larger subluxations where you don't want to enter the vitreous cavity, for example, a high myope or things like that, then you can do a supracapsular glued IOL and then put a CTR in the capsule so that the whole capsular bag doesn't shrink up. And if you want, you could also do an optic capture. That depends on you. So this will give you a good separation between the posterior chamber and the anterior chamber. There's no, you know, entry of vitreous at all. If, for instance, if you, for example, if you've done a plain glued IOL instead of this technique where you remove the capsule. And also it gives you a long-term, you know, stable fixation rather than having a unstable fixation. So that's my preferred technique in progressive subluxation, which are already subluxated enough and where you don't want to enter the vitreous cavity, where you would like to retain the capsular bag as well.
Doctor, yes, very valuable thoughts. And Dr. Afsar, your thoughts?
I think the vitrectomy part is very important in managing these complicated cases. So for the juniors, don't get carried away with these wonderful videos. Vitrectomy will decide the fate of the eye, and Sun Fake and many others pointed out that very well. So please do that. But I want to recognize Dr. Amar Agarwal and his team for through pupilloplasty and intrascleral fixation versus the suture fixation, Gore-Tex and FIO and whatever. There's a distinct difference between suture techniques of all kinds, and they are very smart techniques, versus intrascleral. And Gabor Shariat and Amar made it so easy for all of us. And now Yamane even further had a great appeal. So I think that you must understand the value and pros and cons of each these two groups of techniques, suture versus intrascleral and this thing. So that's the only comment. Vitrectomy is the key word.
I think there are a lot of questions to ask, but we have to move on because we are running quite late.
If I can say one thing, ma'am, for all the youngsters, like Dr. Vasavda said just now, he has a beautiful video which also won the award. I think something about, you know, choosing. I remember the way the video starts, where you go and the road less traveled. And that shows a very good, you know, teaching. That's a beautiful teaching video about how to do vitrectomy from the posterior aspect and how it draws the vitreous back instead of allowing it to prolapse more and more when you do it from anterior. So if there are any youngsters watching, do watch that.
Yes, yes. Thanks a lot. We shall now go on to our next speaker, Dr. Naren Shetty, who is the head of the Department of Cataract and Refractive Services and the Vice Chairman of Narayan Nethralaya Group of Hospitals based at Bangalore. And he's going to talk on a very relevant topic, 6 unhappy patients, my management plan. I'm sure he'll have to tell us things very different what you have already heard. So on to you.
Thank you so much, ma'am. On the sunset, I'd like to thank ARC for giving me this opportunity. So, okay, so let's decode an unhappy 2020 patient. Now, all of us have been trying to target a 2020 vision. Is that the correct target, or are we missing something? So most of the time we keep looking at the surface and we actually miss the whole picture. So when you look at this two patients here, when you look at the topography, patient 1, you simply go ahead with the cataract surgery, you should be all good. But in patient 2, if you don't look closer and you go ahead with cataract surgery, definitely you're going blind into something and you will land in the trouble. So the point is, if you look closer at patient 2, if you look at the epithelium, there's a lot of irregularity of epithelium which is going on, and we need to treat this first and then move ahead. So whenever there is irregular epithelium, what happens? The K values, what you get is very unreliable, and because of which the post-operative outcome will not be that great. Especially if you're going for a trifocal patient, you will really land in a soup. Now, when we look at corneal epithelial remodeling post-cataract surgery, if you can see this data, basically the epithelial disclosure index can vary from patient to patient, from eye to eye. So we need to be really careful on how we handle these kind of patients. And if you have a set of patients who have good epithelium, good corneal nerves, you're all good to go. But if you have patients like this, where you have a lot of irregular epithelium and abnormal corneal nerves, if you do not treat it, you will definitely have abnormal wound healing post-surgery. It's actually a beautiful or an excellent cocktail for a disaster. So basically, it's like if you do have a bad OSDI score, you have poor nerve regeneration. This leads to poor wound healing post-surgery, and which in turn causes bad optics, and the patient will complain a lot of glare and halos post-surgery. So let's look over a case. Here's a 45-year-old male patient with such vision with cataract, and he wanted a multifocal IOL implanted in his eyes. So these were the scans, and this is the EKR map. And if you look at the epithelial maps, you can see a lot of irregularities. So you need to treat this first. So what we did is we put the patient on doxycycline for a month, and the steroids and lubricants and also cyclosporin, and reviewed the patient at 4 to 6 weeks. And then when we looked at the epithelium, it beautifully healed. And then we went ahead with the planning of the surgery. Now, when we look at just monofocal lens, let's not look at the premium lenses. When we look at monofocal lens, we have traditional and aspheric. Traditional has positive spherical aberrations, and the aspheric has either 0 or negative AS. So when you look at the cornea, basically it has positive SA, and the conventional has positive SA. So this in turn amplifies it and creates a lot of high order aberrations, and this leads to poor vision, especially during the night. So when we look at the aspheric lenses, we have the negative and the 0. These are the list of lenses which are available. Now, a simple decision tree on which lens to use. Let's say if it is prior hyperopic LASIK, then you can go with a traditional or a positive SA lens. If you have a prior myopic LASIK, you can go with a negative SA. Now, if no refractive surgery was done, if there is a higher chance of decentration, always go with the 0 SA, because even if the lens rotates, it won't cause much trouble to the eyes. And if there is a less chances of decentration and you're more concentrating on depth of field, then you can go with the 0 SA. If you're looking at image quality, you can go with the negative SA. Now, let's look at a multifocal or a trifocal lens patient. How do we turn these 6-6 frowns into 6-6 smiles? So the first and foremost is to prevent it. How do we prevent this? Is to choose the right patient. It's very important. We need to have certain basic equipments to do so. First and foremost is a good slit-lamp examination, actually one half the battle. Always look at the tear film. Also look at the pupil size. Keep it a range of 3 millimeters to 5 millimeters, photopic and scleropic respectively. Angle alpha, try to keep it within 6 millimeters. If it is always borderline, always you can go for the EDOF lenses. They do a fantastic job and a little more forgiving. Always go with optical biometry because it's not person driven. Always go with, you need to do a topography and also look at the epithelium also to make sure does not, there's some kind of inflammation happening, and also there's a lot of epithelial irregularity, we need to regularize it and then go ahead with the surgery. Please do not forget a macular OCT. It's become a pretty standard for any cataract surgery because you can easily miss out certain subtle changes in the macula, like epiretinal membrane, when you do your fundus examination. IOL formula, I think, as of now, the Barrett's Universal 2 works in most of the cases. It works wonderfully, so you can just stick to one formula as of now. And this is the most important step, is counseling. You really need to sit with the patient, give some chair time, explain to the patient, and make sure the patient has more realistic expectations. That way, you're rest assured that patient is always happy. Now, if at all the patient does have astigmatism, please have a threshold. Anything more than 0.5, please do implant a toric lens, especially in these trifocal and multifocal patients. So if you have a markerless system, fantastic. It really makes your job so much more easier, and it makes it more accurate, in fact. So when you look at when you compare a marker and a markerless system, actually the quantity of vision, not much of difference. But the quality of vision, there is a significant difference, especially when you're doing planning a trifocal lenses. There are a lot of publications on the same. So let's go over a series of cases. So here's a 6'6" unhappy patient with a lot of glare and halos. And if you look at the scans, there's a lot of aberrations arising from the cornea. So we looked at the tears. Actually, there's a lot of scattering occurring from here. So we put the patient on dry eye treatment, and the patient healed beautifully. His visual quality also improved following. The next thing is, again, a post-multifocal IOL patient complained of a lot of glare and halos. And when we look at the scans or the optical quality, it's pretty bad. And when we look closer, actually, there was a decentration of the lens. So any decentration, the smallest change in decentration, anything like 0.7 and more, is a lot of this halos and glare, because it really affects the quality of vision. Now, PCO is something that affects these kind of premium lenses on the early stage. Please do not shy away from doing a YAG in these trifocal patients if the patient complains of some kind of vision disturbance. So here's one more patient who's come with a lot of glare and halos, and this is a post-monofocal IOL implant, and looks perfect, everything looks good, even the visual quality looks fantastic, no issues at all. And when we look at the retina, again, the fundus looks good, even the OCT looks normal. So we thought, okay, let's dig deeper. So we did a wide field ERG, and again, it was within limits. So we did multifocal ERG, and we could see a reduced density of the first order response. So basically, it was an occult macular dystrophy, leading to post-operative glare. So sometimes, this usually rarely happens, but these kind of machines usually, can pick up these pre-maculopathy, so this will really save you in handling premium IOLs. So one more way of handling, making sure that all your patients are happy is to have a questionnaire given to the patients before the surgery. Basically, this will help you to categorize which kind of a personality is the patient. If the patient is normal, you simply go ahead. If it is a miracle, then you need to sit with the patient and make sure, do not counsel the patient alone. The attender should be with them, attender, be it a friend, family, anyone, so that whenever you do counsel, they really understand, and you can always, speak better. If at all the patient has some kind of psychological issue, they will, because the attender was there during a counseling, so the conversations will go much more smoother. But definitely, when there's red flags, please refer the patient to a psychologist, and you wait for 3 months, and after everything sets down, you plan for the surgery. So basically, to summarize, to have a happy, to avoid an unhappy 2020 patient, always choosing the right patient is very important. Counseling also is very crucial. Make sure the patient has more realistic expectations. If you put an unhappy patient into the equation, unhappiness is equal to expectations divided by reality. So always the expectations should be more realistic so that the patient's happy. The next thing is highly demanding patients. Try to avoid or make sure that you counsel them well before we go ahead with the surgery. Always have a closer look for any abnormality. And a good practice does not mean just having more patients. You need to have more patients too. keep your happy patients close and unhappy patients closer. So whenever you do have unhappy patients, make sure you see them more often and make them understand that you are with them till the time they are happy. Thank you for your time.
Wonderful talk, Dr. Naren. You covered all the things which was not covered in the other talks, and that was really very nice. Expert panel, you all have anything to add? I just have one question before we go on to the next speaker. Dr. Sandeep would also take, or Dr. Ramurthy. What are your thoughts about indigenous multifocal IOLs versus modern day IOLs as far as dysphotoptic symptoms or dissatisfaction amongst patients?
Definitely, ma'am. I think it was not just the patient complaining, the doctor implanting the older multifocal lens. They're so scared. Even in big institutes, they're always scared. They don't know what's going to happen post surgery, and who's going to complain. I mean, I've seen patients who have been happy with it also, but there are a large chunk of patients who complain a lot. But with the current generation, it's so fantastic. I mean, if you just follow these set of rules, they do so good. And I mean, you're eager to find who's your next patient to put it in, because they really enjoy it, and they'll be your brand ambassadors in the future. Definitely.
Yes. Dr. Ramurthy, you have anything to add?
Just a Naren, beautiful talk. I think, we have come to a stage when operating on very early cataracts, or to be frank, prelax is becoming inevitable. Patients whose children are getting operated for LASIK, what about me? They have a plus 2.5, +2, they're 50, 55, the lens is clear. And maybe putting in a good multifocal or a multifocal toric, latest versions, as you said, is an option. But these are the patients where it's a challenge both for the surgeon as well as the lens. And their expectations, because is quality of vision. Any compromise on that is not something that is acceptable. Do you do something extra on this subset of patients as far as the preoperative workup is concerned?
Basically, I would say is I would put more chair times up with the patient, because what I try to see, one thing we have to make the patient realize is they keep thinking, okay, I wear the glasses, I have to have this kind of vision. This is what my outcome would be. I feel the best way is, so you remove your glasses. Now, how you see things, you see your distance, you see your near, you see everything. I'll make sure that, post surgery, you will do fantastic. Without, glasses, you should be able to manage. If we say like that, so what happens? They'll always think, okay, without glasses, they'll keep comparing without glasses with glasses, especially in very early cataract stages where they are almost like 6'6", and N6 with the glasses. So such patients, we have to take their glasses out and then say, okay, this is what you are now without glasses. I'll make sure that you will do good. So I think when we say these small words and small counseling, they do fantastic. And plus, they have to be highly motivated. Sir. That is the first criteria, that they should be highly motivated. Then we can plan that. Sir.
Yes, Dr. Vasavda.
Chitra, congratulations. You've been conducting very well, and thank you. Apologies, I need to leave. And sorry, Kamal, Susan, and Jagdish, I can't hear you. But Chitra, wonderful job you're doing, and we are so proud. Thank you so very much. Thank you.
Thank you so much. Thank you, Doctor, for staying with us. And we gained a lot from you.
Thank you.
Thank you. We shall now go on to our next speaker, Dr. Kamal. Again, a founder and medical director of Sharp Sight Centers, which seem to be all over the country nowadays, and a very leading cataract and refractive surgeon. And he's going to talk on a very different topic, like IOL glistenings and opacification, though they are not very many, the current view and management options. And I think Dr. Kamal would like to say there are very many, are they?
No, actually, I guess you should, Dr. Chitra, glistenings are there, and most of us who are using a particular kind of a lens, one or two varieties specifically, would probably agree with me. The best part is that a lot of people who are fixed onto, one particular kind of lens or one particular kind of change is something which we all hate. We hate change in our life. We don't want to shift. So a lot of times, you know, I have some very senior eye surgeons who actually doing a lot of particular kind of lenses with a particular material, and they are having glistenings, but the surgeon will not actually, you know, I'm just trying to look for my presentation. And suddenly I've seemed to lost it. So IOL glistenings are something which are there, more so with the few lenses. Some lenses, zero, negligible, nada. But I would say that, you know, we cannot just wish them away. A lot of my friends say that, I'm trying to, yeah, there, I think. Uh-oh, I think I've accidentally, while working on it, I've done something to the presentation. Corrupted, it's not running. Okay, can I come in later? Can you have somebody else? My presentation got corrupted.
Yes, yes. Dr. Susan, are you around? Oh, yes, yes. I think you will be stepping in earlier and Dr. Kamal will join in. And again, Dr. Susan needs no introduction. She's a director of Dr. Agrawal's Refractive and Cornea Foundation and has a very experienced, innovative, versatile, amazing surgeon. And she's going to be talking on something very important for all of us, DMD challenges.
Okay, I can be heard now, right? Yeah. Thank you so much, ma'am, Chitra ma'am, and everybody else and the AIOS ARC committee for inviting me here for this talk. Lovely talk so far. I will just talk a little bit about Desmus membrane detachments, challenges basically. This is not the conventional Desmus detachments that I'm going to be talking about, but more of challenges. I'm going to show you basically something that I call as the ACE technique, basically acing Desmus detachment, and I put as RDD because R stands for regmatogenous. We'll talk about that a little bit more. Regmatogenous Desmus detachment with open lens capsule. So when your lens capsule is open and you get a Desmus detachment, what do you do? So the case was a very interesting case. This was a 45-year-old gentleman who had basically a white cataract. He presented to us with a history of injury long ago. He's got complete peripheral antisynechiae, as you can see here, white cataract, posterior synechiae. And then when you ask him to look down, he has this ectatic thin patch graph for which he did give a history of surgery many years back. Severe protrusion and thinning, as you can see, you can almost see into the vitreous cavity there. In some of the areas, it's really thin. So now my plan here was basically to go ahead and do the cataract surgery first, followed by scleral patch graft. So you can see what I'm doing now. When I start off with the surgeries, I put in viscoelastic and I do a synechial. So I did this with a rod and I went all around and also did the superior quadrant, as you can see here. And then went ahead and did the capsulotomy. Unfortunately, the capsulotomy part of the video is lost for me. But what has happened is the capsulotomy has been done, and that's when I noticed this. This basically, if you can look carefully, this reflex that's going across the anterior chamber. So now that reflex concerned me because that was not something I expected there at all. This was already a complex case to start with. I didn't want more headaches, but as it's very it's clearly seen, there's a Desmus detachment that's going right across the anterior chamber. And this is now in an eye which also has an open lens capsule. So what are my options here in this case? One is that I close the case and leave it at that, because then what happens is I face the postoperative, a very stormy postoperative period, because I'm going to have phacoantigenic uveitis with all the lens proteins exposed to the anterior chamber. The other option is I go on with the cataract surgery, but that is going to, because the cataract has not even been attacked at all, so that's going to have the risk of an avulsion of the Desmus detachment or an extension of the Desmus detachment and messing it up further. So in this case, this was a white cataract. It was really kind of soft, as you can see here. So I decided that I would go in with a Simcoe cannula and I'll just go ahead and aspirate as much as I can. So that's what I did. I used, as you can see, I've switched off the microscope light for better illumination. I'm using the endo illuminator from the side, and I'm going ahead and removing the cataractous material, and then I go ahead and remove also the epithelium for further improving visibility. But you can see that I'm still having difficulty, and every once in a while I'm scared that the Desmus is going to come and get caught in my Simcoe. Obviously, I don't want to use the IA probe here because things can go really fast and really out of control here with the IA probe. Again, going with the Simcoe, very slow surgery because I have to be so careful that I don't grasp that Descemet's membrane by mistake. So now I decide to, take a breath, pause, and think for a moment. And this is from where the ACE technique is something that I use. I just thought of it at that moment, and probably these are just some things that you can keep in your mind when you attack or when you face these cases, and you have to kind of decide about how you're going to proceed with surgery. So you can see what I've done is I've fixed an anterior chamber maintainer here. That's a trocar anterior chamber maintainer, but you could use any kind of anterior chamber maintainer. And what I've done is I've connected it to the air pump. So you all know, I guess, that we use a fish tank aquarium air pump. We've been using it for long for our phaco surgeries for giving us gas forced infusion, and that comes through a millipore filter so that everything is sterile. But you could also connect it to the vitrectomy machines, the fluid gas exchange system of the vitrectomy machines. And when you do that, keep the air coming out at a pressure of about 5 to 7 millimeters mercury or 5 to 10 millimeters mercury. That is low pressure air infusion. And what happens is this gives you the stream of bubbles. So what the stream of bubbles does is it holds the Descemet's membrane up while you still go ahead and do your surgery. Now you can see that intermittently, there's the stream of bubbles, it holds it up, and you can go ahead and remove the cortex. If you put off the stream, what happens is, you can see now, if I put it off, it's the Descemet's membrane gets caught. But if you put it on, it holds that detached Descemet's membrane up against the stroma with each subsequent bubble that comes out, it holds it up. The key points are not to have it at a very high pressure, because then the whole antechamber just fills up and you can't see anything, but to have low pressure infusion going on. Here, what I've done, of course, is just use a posterior, an inferior approach as well for removing the rest of the cortex. And I'm also doing intraocular lens implantation under air, so the Descemet's is held up. The other option was, of course, to have used viscoelastic to hold it up. But what happens in that situation is you've got viscoelastic in the interface, and that itself can interfere with the reattachment of the Descemet's membrane in the postoperative period. So I didn't want to do that. Or you could also, if you feel comfortable doing that, you could use a mixture of these techniques. You could possibly use viscoelastic with air pump, and all of these techniques are going to help you increase the chances of success of your surgery. And every little bit that helps in these difficult cases is really helpful. So that's what I call as the ACE technique. ACE standing for air pump assisted cataract extraction. Air pump, A for air pump, and then cataract extraction. For when you face a situation where there's a Descemet's detachment and an open lens capsule, and you want to continue with your cataract surgery. And then go ahead and just complete this. This is all just, of course, routine. Put in the scleral patch graft, and you can see there the margins of the Descemet's detachment right there. Back up again, properly, reattach. This is intra-op. The subtitling is wrong. This is the end of surgery, and now you'll soon see the post-op 1 week where the patch graft is good and everything looks good. But unfortunately, the peripheral anti-synocape reformed and the IOP raised, so I put in an AGV. Ahmed glaucoma valve, and then the patient did well subsequent to that. So this patient came recently, 5 years post-op, just about a month back. Post-pandemic, he wanted to come and get a checkup. His best corrected visual acuity was 618 part, which was maintained. His IOP was 15 on 2 medications, and his fields were maintained, and he was really an extremely happy patient. And this is his cornea right now. The central cornea is clear, but the periphery where he had peripheral anti-synocape, even pre-operatively, continues to have that, and there's a epithelial hypertrophy. But the central cornea is clear, and he's having 618 vision. So this was a very happy patient, and this was just a technique to show you the ACE technique again, which you can use to just salvage certain situations where you're in difficulty. I wish Dr. Vasavda had just stayed behind for this talk as well, because this case is something that I borrowed from him. In fact, I have it. I'm sorry, I'm not on full screen. This video courtesy is Dr. Abhay Vasavda. And look at this case. This is basically a post-op, beautiful phaco done. Expected a crystal clear cornea post-operatively, obviously, but then it was not so. And if you look at the replay of the video, you can see this fluid wave that's going across the Descemet's membrane. And this is what I call as the bullous Descemet's detachment. And we classified basically Descemet's membrane detachment into different types. And this is my classification. Basically, it classifies it into regmatogenous, tractional, bullous, and complex Descemet's detachments. And each of these are tackled in different ways. So what we as cataract surgeons most frequently come across is regmatogenous DD, but you also have to know that there is an entity called BDD. Again, these are rarer situations, just as in the previous case that I showed you. You don't always see the much more commoner variety is regmatogenous, but if you see this, you do need to know how to recognize it and manage it properly. So it's a very different kind of Descemet's detachment, and it generally comes near side ports. where the incision is small, you do stromal hydration at the end of a surgery, and then everything was uneventful. But during the stromal hydration, the fluid wave, instead of going through the stromal layers, actually goes and detaches the desmus membrane. And you see this well-defined borders of the desmus membrane. It's a bullous DD. Here in this particular one, you can even see a fluid level. And the treatment here is really very simple. All you have to do is, this is how the desmus detachment is, which means that there's basically no break that is large enough to allow this trapped fluid to escape. So all you have to do is create a break in that desmus membrane and convert it into a regmatogenous DD. So then your supradesmatic fluid can escape. You can do a pneumodesmatopexy and your desmus would be attached. So very simple technique indeed. If you identify it, you can manage it right there before you finish the surgery, and your patient will have a clear cornea the next day instead of having an unhappy patient with a detached desmus membrane. So this is what the relaxing desmatotomy is. It's as simple as that. Just make a keratome cut so that goes across the desmus membrane in that area. Now you've created an opening in the desmus membrane, and you just go ahead from the opposite side and inject air, and that expresses that fluid that was trapped above the desmus membrane. And the rest of it is just like the management of a regmatogenous desmus detachment. And you can see that this patient, who had actually undergone air injection twice, and then was referred to us, resolved with just that simple treatment. So just remember that these two techniques are there for more rarer cases, but really they have their own advantages in many ways, and this is something that possibly every cataract surgeon should be familiar with. That I'll come to the end of my presentation. Thank you so much.
Yeah, that was a very explicit, completely thorough talk. But for a person who doesn't have access to ASOCT, what would be your clinical clue to identify desmus detachment in that eye?
So basically, ma'am, both these techniques that I showed, I wanted to just let everyone or let the younger people know that these are things that you should look out for on table. And on table, most of us don't have anti-segment OCT. So one is that fluid wave that you can sometimes see across. Second is you can actually sometimes see the shimmering of the desmus membrane intraoperatively, because at that point of time, your cornea is still clear and you can still see through. It's only by the, later that the fluid starts accumulating into the stroma and then it becomes edematous. So these two are basically for intraop management. But if you see the patient post-op and there's already stromal edema, and you don't have an anti-segment OCT, you have to suspect. You put it into a very thin slit, your slit lamp, put off the room lights, and look carefully. And very often you will be able to make out the desmus detachment. And you can also, you can also, if you've done the surgery yourself, have an idea about the type of, what happened. The events of the surgery will also help you identify. If your surgery was reasonably atraumatic, but you still have edema, that should, make you suspect a desmus detachment. Or if you've got a lot of phaco energy, phaco power used, or, dense cataract, then maybe it's just striate keratopathy and you could wait for it to resolve. So basically, it's a clinical judgment if you don't have an anti-segment OCT. The anti-segment OCT is a huge advantage when you have corneal edema and you want to differentiate.
When would you think of air bubble and when would you think of a C3F8 gas?
Ma'am, C3F8 is where, you have inferior detachments which are more difficult to reoppose because the air doesn't stay there. The air tends to float up, and the air bubble, if you just put air, it may get absorbed faster. When you want a longer period of, gas tamponade in there, you can use non-expansile concentration of C3F8 or SF6. For more detachments that you expect to be more difficult to reattach, for those you use this. But frankly, ma'am, I have kind of stopped using C3F8 non-expansile gases for some time, and I use only air. And that's because I also do air pump assisted attachment, on table when I have these kind of desmus detachments, which are more difficult. So if you use the air pump, it kind of helps intraoperative attachment.
No, if it's a DM detachment elsewhere which has come to you and you don't know the course of the intraop thing, so I wanted to know when you would use air, when you would do C3F8, and when would you do an inferior PI.
Okay, you mean to say, ma'am, that if you don't have the ASOCT also and you're not sure what's happening. So in that case, what you can do is on table, you can use trypan blue to stain the desmus membrane, use the endoilluminator from the side, switch off the microscope light, and that generally will let you see through the edematous cornea also. You can remove the epithelium, and that would generally let you see where the desmus membrane is. You can figure out the DM dynamics, see how it's moving around in the anterior chamber, see where it's attached and see where it's detached. And then based on what I said earlier, you put in C3F8. A PI is a must if you're leaving a full bubble in the anterior chamber, because otherwise you'll end up with a pupillary block. So an inferior PI, in fact, is a must. You could do it with a vitrector or with a needle or even through an inferior incision.
Thanks a lot, Susan. There's so much more questions to ask, but we are running so late. So Yeah. So we shall now go on to Dr. Kamal. I don't know whether he's going to show this video or he's going to show something.
Dr. Chitra, can you hear me?
Yes,
okay.
yes.
I've changed the presentation. Actually, as you know, I was caught in my center, so I was rushing back home. There was a lot of traffic, so I stopped at my sister's house. So I had an old presentation on glistenings. I was working on it. I saved it. Something happened. So I'm trying to repair it. It's not repairing. It's not able to play back. So before I start my presentation, I'll give you the gist of what I wanted to say in that. Glistenings are real. They do happen and they do bother the patient. It is just that, you know, we become oblivious to them and we kind of deny them. If I had a choice between a lens which had no glistenings and glistenings, of course, my logic is I'm taking an unclear lens, a lens which is cataractous, a lens which is totally non-transparent, and replacing it with a transparent clear lens. And that is the way I want the lens to be. So in case it gets glistenings, this is not what I want. Number two, glistenings are actually micro vacuoles of water within the particle, the stroma of the lens, the material. A lot of studies are saying that, you know, there are more glistenings in compression molded lenses or tumble polished lenses. But the basic point is the ball stops at the material of the lens. Number two, the reasons for glistenings a lot of times has been attributed to the temperature where the lens has been stored. Slightly higher temperature lenses with a material which is more prone to having glistenings are the ones where we see glistenings. In an elderly person, let us see what happens. A yellow colored lens, when it gets glistenings, this is what it does to the patient. Most of these old patients will have a senile miosis. They'll have small pupils, so there's less amount of light entering. Glistenings reduce the contrast, even if marginally, for argument's sake, they reduce the contrast. Now, this patient in elderly age group are more prone to having macular degenerations. So macular degenerations, small pupil, glistening, a yellow colored lens, which blocks your blue light. As we all know, we require blue light to see in the lower light contrast, maybe in the dark time. So a combination of a yellow lens with glistenings is a catastrophe for this patient. Not just as a pudding or a cherry on the cake, you add these patients, elderly patients who have reduced rod cone density. The rods, as we know, they go down with age. So a combination of all three put along with glistenings in the IOL is a bad recipe. So I think there are so many studies by Dr. Howard Fine. I think he's the one person probably who's reported maximum number of explantations due to pure glistenings. The glistenings are classified from grade 1 to 4. Unfortunately, my presentation is not here. I wanted to show you some of my slit lamp photographs of glistening. So I feel in one particular big brand of lens, multinational, is very well known to me to have glistenings, and that's the lens which I've stopped using for last 10 years now. So I don't use that lens anymore. So having said that, now I think I will now come to my presentation, which I'm trying to show. It's very interesting. Dr. Chitra, am I allowed to run a different presentation?
Yeah.
Okay. Now this is an interesting presentation. I just kind of fixed it for last 10 minutes. I was just looking up my laptop, I had some interesting videos. These are very interesting videos. Some of them are very old videos. Now this is okay. Now, whenever I have a situation, a patient comes to me with a problem, all I try to do is just be calm and think out of the box. So sometimes big problems can have a simple solution. So if we keep solutions simple, keep our mind clear, things will happen. So I have this patient here who reports to me with his father. He came for his father's cataract surgery. And while he was standing, he casually mentions to me that, Dr. Kapoor, I had a cracker injury many years ago, and you know, I got a surgery done in Ambala, and I still can't see. So this is an interesting case which we will see now. He's a 32-year-old male, and he gives a history of trauma. And 9 years ago, cracker injury. But somebody who repaired the cracker injury with perforation, sutured the pupil to the sclera, and there's a bleb there. So he doesn't have any vision practically. So I thought, you know, what can I do for this patient? So again, as I said, thought about an idea. So I said, let me see how I can help this patient. So I just go in, I just decide to put in a viscoelastic, go in with a vitrectomy cutter. Now, some of these videos are very old. You can see, they are 3:4 ratio and bad bite rate and not very clear. But I just dug into my old archive, and the moment I realized my presentation was not playing, so I was for the last 5-10 minutes trying to get some old videos. Now, this is something very interesting. So I create a pupil in between, and I decide, okay, now this is what I do. Once this is done, I'll jump the video. Now I see the patient post-op. Now, once I see the patient post-op, I do a refraction. Patient improves to 618 from vision 5/60, but there is some PCO. So I said, okay, now let me do a YAG for him. I do a YAG and he improves with a myopic glass to 6.6. Then I decide, okay, let me do a PRK. But by this time, there's a lot of fibrosis here and the pupil has gone a little bit irregular. So I do a PRK for him and this patient does well and improves to 6/9 parts. Now, this is another case. This is a case of a lady of my OT technicians, aunt. She comes from, Orissa. She said she was operated 11 years ago. She had good vision, but then after 3 months, she had bad vision. She went back to the old doctor and the doctor repositioned the lens. She improved vision. Then again, she lost vision. So I saw her in the OPD and I saw that there was a PC rent and the previous surgeon had put a tripod lens. In case, if you remember, we used to have this lens called the AIOS Tech lens. It was a German company. This was put on a PC rent in the sulcus, and this lady was a myopic. So she had a huge sulcus. So probably what was happening for her was this lens was coming up again and again. So first I thought I'll explant the lens, put a sulcus fixated lens. Anyway, this is a very, very old video. This is probably a 15-year-old video. So I decided, first of all, let me do vitrectomy because, I thought there was no vitrectomy done by the previous surgeon. So I just have one instrument with the fluid flowing in on top of the lens. Then I try and see, does my lens go back in again? No. Then I do more vitrectomy. Once I do this vitrectomy and now the lens is absolutely settled. Now I just want to be sure that the lens goes back into the sulcus and it doesn't come up again. So what I had done was I had a 1 diopter lens, which was a simple, normal, single piece hydrophilic lens. Just a minute. I think I jumped the video by mistake. Yeah, this. Now what I do is I push the lens back in sulcus and I take another 1 diopter lens and I push this lens on top of this lens. So I'm injecting another lens. Once this lens is pushed in, I take another 0 diopter lens, slightly enlarge the wound there. Now this lens holds the earlier lens in place. So since this is a hydrophilic lens, the white to white of this patient was approximately around 12 point something. So I use a 13 millimeter hydrophilic 1 diopter lens to put on this. And I checked for, this is a very, very old video, but since this was very interesting, so I thought it will be different to see this. And I saw this patient after 3 years of this surgery, approximately 12 years ago, and the lens was still in place and the patient was 612 unaided. Now, this is another interesting thing I have started doing is I've been doing this since 2014. There are a lot of times these fibers on the posterior capsule, and these fibers will bother the patient. They will give early PCO, or maybe they'll have these opacity, they'll opacify, look dirty the next day. So what do I do for these patients is I just dip the scleral lip, use a 27 gauge blunt cannula and jet the posterior capsule. You will see here again, just dip the cannula. And as we move along in the video, we'll see worse situations with posterior capsular plaques also, which can be brushed away by just dipping the scleral lip and keeping a 30-degree angle and making sure that the fluid wave hits the posterior capsule at approximately 30 to 40 degrees. Now, this is another a big plaque. See how this plaque is cleaned. Now, a lot of times surgeons would use probably a cap vac mode, but I think in a beginner's hand also, this is a very, very safe technique, and this can actually. So in case you put the lens, you can go behind the lens, make sure, all you need to make sure is that you dip the scleral lip and you just, while you push in the fluid, make sure that the fluid gets a path to come out. And this way you can clean the posterior capsule. Now, sometimes the solutions are not so simple. Now, this is a case which was operated somewhere else. This was again another dissatisfied patient. The patient was aphakic. There was vitrectomy which was done, but the surgeon did not put the IOL. So this patient came to us. There was a repaired corneal perforation, and there's a big plaque here. There is a PC break here, and there's a complete aphakia. There are adhesions between the posterior anterior capsule and so I will just. So what do is I first break all the synechiae between the posterior capsule. This area is blocked, so I do some vitrectomy. I'll just jump the video. Now, once this is done, there is some vitreous coming from here. So I've done vitrectomy only in this area. I've broken all the adhesions. I put in a 3-piece lens. And once this lens is in, I push in viscoelastic to see that if there's any viscoelastic coming, vitreous coming in here from here. And as I was saying, now I've started using these forceps. This is a bit old video. Now we go ahead to, yeah. So we do the pupil repair, and I do not bother to repair this area because there's a lot of opacity here. And this is how the surgery looks by the time we end. And this is how it was when we started, and this is how it ends. So a lot of times you need to just think out of the box. This is another interesting case. Yes, this is an interesting case. This was operated by one of my colleagues. This was a case of pseudoexfoliation, non-dilating pupil, floppy iris, Fuchs dystrophy, and my associate surgeon lost the CTR behind the iris. Now, what you see is a fibrosed capsular rhexis to the posterior capsule. This is the capsular rhexis, which is totally decentered. The CTR is half inside the bag and half outside. Luckily for me, my associate drew the diagram where she thought she lost the CTR, and that was my only reference point. So the first thing I do is I very carefully and gently break the adhesions between the posterior and anterior capsule. This is approximately 8 to 14 days, if I'm not mistaken, after the surgery. You can still see some corneal edema. So my endeavor is first to be able to separate the anterior and posterior capsule. I do not want to stretch the capsular rhexis because it's getting fibrosed and it might tear. There you can see there's a lot of adhesion between the anterior and posterior capsule, but since there's not been much time there. So now I start looking for the lost CTR where I was told it is. So there I see it there now. So what do I do? How do I get it back is I use a coupling technique. I use a Lester's manipulator, which is a round-bodied manipulator. I'll just show you how I go there is. First of all, I use two-hand technique. I will hook the CTR with one instrument, pull it out. Now with the second instrument, go underneath the CTR, and I realize I'll lose it again. So I pull it out again. I use another blunt instrument to go underneath the CTR and now try and railroad it on top of the iris. Now, once this is done, now I realize that I will need to dial the CTR in, and with the bag, which is already totally subluxated, the rhexis is fibrosed. I don't want to stretch the rhexis more. So then I leave the CTR on top of the iris, go push viscoelastic, and then I use the forceps, which I use for my B-hex expander, to hold it at one edge and dial with the forceps the CTR bag in the back. But if I could see that this is not going to go in one go, so I decide to put in whatever I could, dial it in one part, and leave the other part of the CTR on top of the iris. Now I change the maneuver. I use the same manipulator. I hook the eyelet of the CTR, and now I'm in a position to put the CTR back in again. Now, all this would not have been possible if I was not thinking on my feet, because this patient, the capsule rhexis was very brittle. Now you can actually see the fibrous capsule rhexis that could have torn. So once this was over, all I needed to do was open the suture, push the lens in, and it was over. So I think this is another interesting case, but I guess I'll skip it now. So Dr. Chitra, I'm sorry I could not talk on the topic which I had, but I tried to do best whatever I could manage.
Yeah. Thanks a lot. Thank you very much, Kamal, for, can you stop sharing?
Yeah, I'll stop sharing.
Yeah. Thank you very much. Thanks, one and all of you who stayed on right till the end, because I'm sure we do realize at the end of this 2.5 hours that each of us have learned a lot from the terrific speakers and the expert panel. Terrific is an understatement. I mean, it has been, each of the talks have been so very unique that there was not too much to discuss at all. And I would like to thank my co-moderator who had to leave, and all my entire team of ARC for being there for me always. And as I conclude, I would like to thank Kripal and the AIOS team for always backing us up. Thanks to Sai and Manjula from Numerotech. You can see how we flood your inboxes so that you do not forget our ARC webinars. And I do hope you all watch some of the good ones at least. And thanks a lot to the AIOS, webinar admin, Dr. Anand Sethi and his team. You can see how meticulously and flawlessly they conduct these webinars, and you know, that's a big help for us. And a huge thanks to Entode. If you have an idea of the number of webinars I've conducted, majority or most of them have been sponsored by Entode, and that's such a big relief for us that we don't even have to worry to talk to any of the pharma companies about it. And thanks a lot to attendees. Actually, attendees always are there for us, which eggs us on to do better and better. And we are really coming up with a very nice ARC website, which has all of that placed in a very methodical manner. I do hope some of you attendees go and watch some of these amazing talks and amazing videos, which are shown every now and then. Thank you so much, one and all. Thank you so much, Dr. Sufekji. Thank you, Kamal. Thank you, Ajay. Thanks a lot, Dr. Sandeep. Thanks, Anagha. Thanks, Ramu.
Thank you, Dr. Chitra. Thank you.
Thanks, Naren.
Bye. Good night, everybody.
Thank you, Chitra. I think it was wonderful. Wonderful.